So I immediately took that opportunity and we decided that let's work together on this. Tifac role is going to be a catalyst. We are not expert at everything. What we need to do to find the relevant knowledge institution. So the technical session 1 focuses on that. Rest details will follow as we go along. The second session that we have, technical session, will be after the lunch, and because of minister's schedule, we have to prepone the inaugural part little bit. We will be coming at 2 o'clock. At 2:10 will be the inaugural function, that is right after lunch. So this session and the follow-up will finish at 1:10. We have to follow the time, and then we'll go for lunch. And 2 o'clock minister is coming. 2:10 he will arrive here. Outside we have a demonstration of assistive technology, very selected ones, the ones which are not known to people generally. So those are being demonstrated on the ground floor, in the lawn. That's where the team will also be served. The second session after the inaugural is discussing futuristic assistive technology. And today we see that it may be possible that most of the disability, the barrier need not be, technology can cross the barrier. So we are discussing that part, how futuristic assistive technology can cross the disability barrier. Then tomorrow, the third session actually talks about real-time translation among Indian languages, how it can make us cross linguistic barriers. And so it is today possible that I can talk on Skype in one language, you get translated in some other language, and vice versa. That is being hosted in Tifac building itself. So I will not delay further. We also welcome our chairman, Dr. Kakotkar, and I'll hand it over to Dr. Anju Sinha to conduct the rest of the session.
Very good morning to all of you. It gives me great pleasure to welcome all of you to this plenary session on elimination of anemia in women and children, jointly organized by Tifac and ICMR. Anemia, as you know, is a major public health problem in the country today. The figures for anemia among women and children are truly staggering, despite 30 years of the oral iron supplementation program implementation. According to the National Family Health Survey 4 that recently was released, it is known that more than half of all our women and 3/4 of our children are anemic today. So, to deliberate on these issues, we have organized a scientific program comprising of 7 plenary lectures. I now request the Secretary, DHR and DG ICMR, Dr. Soumya Swaminathan, to kindly give her welcome address on the occasion of this program jointly organized. Dr. Soumya Swaminathan is an Indian pediatrician and clinical scientist known for her works in tuberculosis. She is currently positioned as Secretary DHR and Ministry and DG ICMR. She has conducted clinical trials investigating treatment and prevention regimens for TB among HIV-infected patients. She has studied the nutritional status of HIV-infected persons with and without TB and performed a study of nutritional supplementation, which has led to adopting this intervention in the ART clinics. Dr. Soumya Swaminathan.
Professor Kakotkar, and senior colleagues from all the different institutions and participants, friends from across the country. I think that it's nice of Tifac to have organized this half-a-day session just to discuss the problem of anemia in our country, and also for having put it as one of the grand challenges in the vision document. The vision document is really a very impressive one. It's been led by Dr. Kakotkar and a team of very eminent scientists. And I think all of you have received a copy, and if you see that document and the vision for 2025, we really have, we come to realize what are the big challenges that we have to overcome to actually get there. It's also, as far as health is concerned, in line with the Sustainable Development Goals that we need to achieve, that is health for all, the universal health coverage, and to attain highest level of physical, mental, and emotional well-being, not just the absence of disease, and particularly to eliminate all causes of avoidable maternal and child deaths by 2030. Um, the MDG year in 2015, we were short of achieving the goals 4 and 5 on maternal and infant under-child mortality because of several reasons. But I think one of the important reasons is the chronic problems that we have, specifically undernutrition and anemia in our women and children. And if you look at the NFHS 4 data that's just come out, it's only the partial data that's come out now for all states. But even though it shows a decline in the rates of stunting and undernutrition and wasting, but there are still many of the states that have been covered in this initial phase still show levels of stunting of over 40% in children under 5. So there are some states that have made progress uh, where the levels of stunting have reduced, but even then they have reduced to levels of about 25%, which are still way above levels seen in sub-Saharan Africa. So I think similarly with anemia, with all the interventions and programs that have been ongoing for so many years, we still have levels of anemia that are over 50% in women and in children. Recent analysis has also linked the role of open defecation and the fact that communities or populations where there's a lot of open defecation, lack of availability of sanitation, are closely linked to rates of childhood undernutrition. And this is a fact that is, I think, not commonly appreciated. So really, when we talk about Swachh Bharat, it's not only a question of dignity and providing everybody adequate clean sanitary facilities, but it's also a question of health. And I think that's why the Swachh Bharat and Swasth Bharat need to be linked clearly in people's minds, because very often I myself interacted with people who practice open defecation, and when you ask them, they really don't understand in what way it could be having any harmful impact on anybody. Try to tell them that it's actually harming your own children's health in the long term. That connection is not made by most people. So I think that anemia is one of those issues which is impacted by different sectors. It's not only a health sector issue, and perhaps that is why the iron and folic acid program has not had the desired impact. Because it's not simply a question of giving more iron, but it's a question of how bioavailable it is, whether it's being absorbed properly and assimilated. And also the fact that you need multiple micronutrients, as well as, of course, enough of macronutrients in terms of energy, calories, and protein, in order to have a good hemoglobin or to have a good body weight for age and so on. And studies by NINE, I think we'll discuss later in the panel discussion, have shown that multiple interventions have a much better impact than iron or iron and folic acid alone. And I think we also we will be listening to some of the solutions or practices of traditional medicine, Ayurveda and so on, because they have a more holistic approach to tackling health rather than the allopathic approach, which is more reductionist. We try to identify the core of the problem and treat it. And whereas the traditional approaches have a look at the individual as a whole and try to address the issues. So perhaps for anemia, that's what we need to think along those lines, rather than which particular supplement should we be giving. But in any case, I think it's a very good opportunity for all of us really to share our thoughts, experiences, and evidence, and then have a plan in 5 years. And I think this plan should include an implementation agenda as well as a research agenda. Because I believe there are many things about anemia that we still need to understand, and where we need more research to be done. Could be side by side with implementation, so what we call implementation research. But I think we also need to drive our policies in a direction which is more based on the evidence which is available to us. There's no point Einstein, I think, was the person who said that if you keep doing more of the things which you know are not working, you're destined to fail. So there is no point in going ahead or going on with programs which have not had a desired impact. I think we need to take a look really and think about how we redesign. So ICMR is in a position, I think, to play a key role here, where we have all the evidence. I think we need a good analysis. I was talking to Dr. Prema earlier today. All the huge amount of data we have now from the NFHS, from the AHS, from the NNMB, from the DHS, we have at least 4 or 5 surveys which give us data on nutrition and anemia and general health of the population. So we need to really do some very critical analysis and thinking about what is this data telling us. Of course, we can clearly immediately identify the districts in our country which are should be a high focus or high priority districts because all the parameters are poor. So even if we look at maternal mortality rate, for example, it's quite amazing. On the one hand, you have a state like Kerala where it's somewhere in the 60s, and then you have Assam and Odisha where it's in the 400s. And within that also you will see within Assam, if you go and look at the districts, we find that the upper Assam has much poor, very bad maternal mortality statistics compared to. So this is related to the health system factors also. The poorly functioning health systems, very poor care, antenatal and during delivery, and a lot of deaths which happen both in the mothers and the children. So we may need to have the district focused, state focused programs as well, rather than having a national program which really doesn't look at contextual factors. So I think more local level planning would also probably help. But I think the first step is analysis and looking at the data and the reasons, identifying the gaps in knowledge. And here the gaps in knowledge are both in terms of diagnosis, easy detection, finding out the cause of anemia in a particular individual, and then the good treatment strategies and monitoring and surveillance. So with that, I would like to thank the organizers for inviting me to be present today and look forward to the discussions during the day. Thank you very much.
Thank you, madam, for your important input on all the aspects of the today's agenda. Our next plenary lecture is by Dr. Prema Ramachandran, who is Director, Nutrition Foundation of India. She will deliver a lecture on eliminating female and childhood anemia. Dr. Prema Ramachandran.
Very much for giving me an opportunity to talk about the subject, which have been one of my major areas of research interest right through my life, and one where we have never been able to really achieve the impact that we felt was very much within our reach. And therefore, very, very happy that anemia and elimination of anemia has been taken up as one of the grand challenges in this 2035 vision. If we look at anemia, Indians have been in the forefront of research on anemia and its health consequences right from the beginning. Indian research workers have helped to evolve guidelines for prevention, detection, and management. The country was the first to develop the National Program for Prevention and Control of Anemia in Pregnant Women and Preschool Children in 1973. Anemia is easy to detect. Prevention treatment protocols have been in place for a long, long time. Despite all this, India's position as a global #1 in prevalence of anemia and its consequences have remained unchanged in the past 6 decades. Why is this so? I will just briefly show you 3 pictures on prevalence of anemia in preschool children, in women as a whole, and pregnant women. In all, India is the number one, without doubt. And because of our large population size, we not only have the largest proportion, but also the largest number of anemic persons in the world. Anemia is prevalent not only in pregnant women, adolescent girls and children, but right across. And it is there both in urban and rural areas. It's also seen even among the high income and highly educated classes. So it's a widely prevalent problem. Why is it so common? Basic problem is we do not eat green leafy vegetables at all. We don't even consume 50% of what is requirement. Even today, earlier the consumption was much lower. As a result, if you look at the nutrient intake, you will find that iron and folic acid average intakes coming from NNMB data shows that 100% of people do not have even 50% of requirement. Studies that have been carried out multiple centers, I'm showing here the data from the studies carried out by NFL and NIA. It shows that irrespective of whether the person is anemic or non-anemic, all persons, all pregnant women have iron, folic and B12 deficiency. Most common is iron, next common is folic acid, but now B12 deficiency is also increasing. There are studies from Bangalore and Pune which report a much higher B12 deficiency. So finally, let us ask the question, why is anemia so common? Because of inadequate iron folate intake due to low vegetables, especially green leafy vegetable consumption. Why is it so? Not readily available, not really tasty. We don't have high fresh food consumption. We cannot afford it economically or ecologically. So what should be our effort? It should be to increase the vegetable intake on a high priority. Poor bioavailability of dietary iron from the fiber rich Indian diet is a concern for anemia. But we should not attempt to change this diet style because this is what protects us from obesity, cardiovascular disease, and cancers. What can we do technologically to increase the iron intake? India is number one or number two in vegetable production, but access to and affordability of vegetables are major problems. Why is it so? Because post-harvest losses due to spoilage in transport is 40%, and this drives the cost up for the consumer and drives the profits down for the producer. We should have innovative low-cost technologies. India specific. What are they? Solar drying, that if necessary by electrical drying of many vegetables, especially green leafy vegetables. This will increase shelf life, reduce wastage, reduce transportation charges. We could also look at leaves which are not usually consumed. One example is cauliflower leaves. And the commonly used one, palak, methi, and radish. They can all be processed, dried, powdered with good quality control, packaged in soap. This processing of vegetables will provide remunerative employment to rural youth and enable the horticultural sector to achieve full economic potential. Processing cuts down preparation time at home, ICDs, and in schools, and therefore make food-to-food fortification, that is, use vegetables as the fortificant, possible and affordable. We have huge number of iron folic acid rich vegetables. For the first time, the Iron Plus initiative gives due predominance to prevention of anemia using sustained dietary improvement. We should go ahead with that pathway because that is ultimately the most sustainable one. But the returns are not going to happen in short term. So we should look at alternatives, which is food fortification, iron fortified iodine salt. Use of iron fortified iodine salt has been shown to reduce deterioration in iron status and also achieve some improvement in immunity. Happens slowly, 0.5 gram per year. But potentially, DFS is one of the most useful mechanisms for nearly doubling the iron intake in the 1.23 billion population. Consistently over the next several decades at an affordable cost without changing access and dietary habits. And therefore, this should proceed as well. Finally, one question is commonly asked, why should we worry about anemia? We should worry about it because in children it causes increases in infection, lower attention span, poor concentration, all of which impede cognitive development. In women, easy fatigability, reduction in work capacity, and immunodepression, and susceptibility to infection. So it affects everyone. In pregnancy, it can be a disaster with higher preterm and lower preterm rates, higher perinatal mortality, and even increase in maternal mortality if it is severe. In India, even today, anemia ranks as a number one cause of death. Per se, it causes about 20% of maternal deaths. Indirectly, it accounts for another 20%. These figures have remained unchanged. Actual figures, number of deaths have come down as a proportion, however, anemia remains an If so, there are going to be situations like pregnancy where it is important for us to detect anemia. How do we detect anemia? It's diagnosed by hemoglobin estimation. What is the appropriate technology for hemoglobin estimation? Now, in the 60s, India did not have the equipment and manpower for hemoglobin estimation. And therefore, we looked at two simpler alternatives, Calculus scale, which is an optical color matching of white blood. It's graded at 2 grams per DL. Optical color matching is always inaccurate. And 2 grams per DL is too wide a match. Salis hemoglobinometer is another widely used in the sector. You have to have environment HCl and distilled water carried all over. It is time consuming, 20 minutes per test. And again, the same problem of optical color matching being dicey and not accurate exists. What? This is very well known to everyone. So clinicians on one side know that they are not getting accurate results needed for grading anemia, providing treatment, and monitoring response. And people also know this. So therefore, detection and treatment of anemia is not getting the attention it is. Sometimes it is said the latest and the most expensive is the best, but that is not necessarily so. For example, there is one method, HemoQ, which has been used globally in DHS and in Indian NFHS. Why did they use it in NFHS? Because DHS uses the method. It can be done in the field by survey personnel with no pipetting skills. Results are immediately available and can be given to the survey. What did it show? NFHS 2, which is 1999-98, showed that ever married women and pregnant women, prevalence of anemia was similar. And at that time, the immediate conclusion was this is the impact of India's successful anemia control. But we have excellent clinicians and nutrition scientists. They said, no, that's not what is happening. There has not been a decline in anemia. Huge number of investigators compared HemoQ with sign metal. Some of them are present in the audience today. Clearly showed that HemoQ overestimates hemoglobin and underestimates anemia. The relationship between HemoQ and sign metal is non-linear, so no correction factor can be obtained. Conclusion: do not use HemoQ if accurate estimation of hemoglobin is required. Globally, people came to understand this problem a little later. You have prevalence of anemia from all surveys using science, which happened in the WHO report 1995. And women have a lower anemia rate as compared to pregnant women. While the surveys that were done in 1995 to 2005 predominantly come from DHS, non-pregnant women have higher levels of anemia than pregnant women. This is physiologically not. And the rationale, most probably it is because of differences in the ways in which anemia was estimated. Remedy, however, is very simple. Shift the estimation of hemoglobin using silent hemoglobin method in all sectors. The needed equipment and manpower is there in all hospitals. In hospital settings, collect blood in rapid solution for hemoglobin estimation. In the community setting, collect blood in the filter paper, dry blood spot method, get it transported to labs for hemoglobin estimation. NMMB, ALHS2, ALHS4, AHS have all used this technology successfully. Hemoglobin results can be communicated by the ANMs using it. It's extremely important. If anything can go wrong, is a multi. We should take appropriate steps to ensure accuracy of everything and accuracy of hemoglobin estimation. What is the potential impact of such an accurate diagnosis? We can provide accurate anemia to all persons accessing all levels of care within all the existing constraints without any major additional impact. Patients and people will see they get accurate results at an affordable opportunity cost. Clinicians will respond by following treatment protocols and make treatment of anemia meaningful. People also will respond by adhering to treatment and following follow-up schedules and benefit. The country will be happy using the global number one status. Thank you.
Thank you, madam, for your comprehensive review of the present situation the country is facing on anemia. You touched upon issues related with food fortification, low-cost technologies, and issues with diagnostics of anemia. Our next speaker is Dr. A.T. Tapke, who is a former Vice Chancellor, Ayush and Health University, Raipur. He will give a talk on coverage in Technology Vision 2035, Medical Science and Healthcare Sectoral Document.
Yes.
Well, good morning, all of you. For me, it's a great honor, and I feel really grateful for Dr. Ramchandran Madam, Swaminathan Madam, and of course, the Tifac Dr. Goswami and others. A very, I think from the audience I see it, I'm one of the most remotest place person who has come to. And I would like to see the problem through a different vision. Repeat, it has been very nicely said. We have a very major problem, anemia. But before that, we should think of malnutrition. Unless we think of malnutrition, we may not be able to get rid of anemia. And this has been discussed very nicely just now. Has been also been discussed. This also. This is a first slide I thought which we can think the intervention. This is the original work on iron metabolism, Dalman, and a very simple intervention like 25, 50, 100 to 50 milligrams of ascorbic acid added to non-heme iron containing diets can increase the iron absorption 2, 3, 4, up to 6 times increase can get you. And this is what one intervention I thought we have to very carefully. Yeah, this is a very important. I am coming from a state, Chhattisgarh, having 10 crores population of tribal, biggest share. It is 36% tribals in Chhattisgarh of population 2.2. Right? There is little. Uh, this state has about 31 tribes, which means that some districts have more than 60% tribal population, and of these, 5 primitive tribes are also there in Chhattisgarh. And this is a data which tells how poor is the situation, because if we want to do some intervention, we will have to start from this end rather than starting from the top. It's a very poor literacy, 10% was the highest. Pahadi Korwa is one of the primitive tribes of Chhattisgarh. Kamar is another primitive tribe of Chhattisgarh. Gond is not primitive, but it is equally backward. All deliveries were by untrained person, 95-98%. And this, since there is another very good presentation, only point which was known that Kamar children were given once a week iron supplementation in school. And what was the observation that by 12 months, these infants, this is a different slide, these infants who were studied, by already they started stunting, high depression, and this is partly because of poor maternal status and poor nutrition, and we had to select those several kilometers before one infant would be seen. This was a cross-sectional study. This slide, I think, this audience should see more seriously, because the persons who had done this, they are from Swasth Sahyog Clinic, they are AIMS Delhi trained doctors. Dr. Jain was in pediatrician, selected for assistant professor in hemato-oncology. There is a hematologist and there is a microbiologist, and their observations, see the huge amount of, they are covering 2 blocks of Bilaspur district, one of the most backward district they are covering. And 59,000 was their OPD attendance, which can compete with any big hospital. And non-tribals, Adivasis, were 40,000 and only 587 tuberculosis cases were. As compared to tribals, 17,560, 601 tuberculosis patients. And Baiga is a primitive tribe. And in only 1,300 Baigas were examined and 64 very high prevalence of tuberculosis. And this interaction of tuberculosis, malnutrition, is creating a very, very big problem, which I think we cannot handle just by simple meeting. This, of course, has been discussed, but what is important that our energy and protein consumption is getting down, but this protein depletion, which is more in urban population, is going to create further problem, because whatever energy requirements are there, they will be utilized by consuming this protein also, to an extent that hardly any protein will be available for tissue building, cell growth, epithelial, bone marrow, and that is one of the reasons that we are not able to solve this problem. Now, what was the action plan? If we see this tribal population, if we see this tribes which forms 10 crores population of our country, and they are in, just imagine, central India, Chhattisgarh, Bihar, part of Odisha, northern Tamil Nadu, Jharkhand, part southern MP, they are all up to Gujarat. There is a huge tribal population. And if you want to start, let us correct one block. If we select one block, it should be one tribal, one rural, one urban slum, and one industrial cluster. Like Chhattisgarh, we have 5 or 6 clusters where people are migrated. They are in a very small, compact colonies. The industry closes, they are unemployed, they are away from their home, they are having nutritional problems, they are having infections including HIV, and they are also having psychiatric problems. So if we select one block and try to do interventions, whatever has been suggested, they are all very, very useful. And whole population to be surveyed, assessment of malnutrition, anemia status should be done, and interventions for 2 months, micronutrients are done. And if during this phase, infections should also be covered. Then only we can assess what is the cost, what is the input required, what are the points where we are failing, and then we plan a plan which is for district level. I can tell you one block, 2 to 3 lakh population, depending on state, and each has 5 to 6 panchayats, and some 5 or 7 blocks will form one tehsil. So block is a reasonably good way to plan nicely. Now, what are the interventions? One thing which was the last is identifying the carriers of thalassemia, various hemoglobinopathies, which is huge belt right from Bengal, Bihar, part of Odisha, Chhattisgarh, Garar, part of western, southern MP, and up to Gujarat. We have so many sickle cell carriers. Now they and other group in the north or in thalassemia carriers where देखो साहब हम 10 साल से आयरन खा रहे हैं, हीमोग्लोबिन बढ़ ही नहीं रहा है, and some of these population also have nutritional deficiencies can be worked out, and if we monitor the environmental sanitation, drinking water, along with supplements, and then only we will know the cost of intervention. Now, what are the points which to be looked, because we still don't have sufficient idea. Carrier of sickle cell and one, what are the infections in these anemic mothers? Why I am talking of this infection? Because if we give iron therapy, there are now plenty of papers which suggest that iron, if given during infection, E. coli, Salmonella, Klebsiella pneumoniae, Staph aureus, the bacterial growth increases. Now, if this is true, how much serious is this problem? And if this is correct, how to treat these infections and how to find a solution to this problem? Because currently we are not giving irons during acute phase of infections as a supplement. So this has to be iron transfer from fetus, mother to fetus is again we have not concentrated, I think, to that extent. And placental morphology has to be also studied very seriously, because if placental weight is less, the birth weight falls, and this is the reason that we get the cycle of IUGR low birth weight baby. And we haven't yet seriously done research on gut flora in normal individuals, in infected individuals, celiac cases, malabsorption, including iron. Now, these are, of course, little repetition, but what is important that environmental and other factors should be looked very carefully, and it has to be a group approach if you want to succeed. Now, where we start? Everybody is doing problem eating. I think the point to start is an adolescent school girl. We are struggling with that. A 10-year-old girl must be first picked up, her nutrition educated so that she is educated, then only she is eligible to become a good mother, and care of newborn and 2 years, that is 1000 golden days concept, should get priority. This can be possible with the existing infrastructure that our country is having in every place. Only thing, it has to be strengthened. And lastly, it is possible because other countries have done it. We are poorer than us, who are less literate than us. So we should only think that a determined approach and a proper motivation is what required. We don't want to see this picture again. A 1-year child looking 6 months, mother who is 22 years looks as if she is malnourished, her BMI also will be less than 18. Her grandmother of this child is just 40 years, but she looks very old and sick. And I think this cycle we'll have to break. I'm sure with this determined approach, we should be able to succeed.
Thank you, Dr. Dapke, for giving an overview on iron metabolism, assessment of malnutrition and anemia in tribal populations, and also pointing towards operational design procedures. We now invite Dr. Dinesh Baswal, Deputy Commissioner, Government Department of Health and Family Welfare, to give his lecture on the current status of the government programs.
Good morning, everybody. I will just take you around what various type of interventions which the ministry has taken. We have followed a life cycle approach actually, and that is what I am just giving you the magnitude of the problem that iron deficiency is the most common nutritional disorder in India. 56.9% ever married women aged 15 to 49, and 78.9% of children aged 6 to 35 months are anemic, as per NFHS third data. Iron deficiency is the main cause of anemia and both affects all age groups. 57.9% of the pregnant women aged 15 to 49 are anemic, just 3. Iron deficiency is aggravated by worm infestation and malaria, which causes blood loss. For pregnant women, anemia contributes significantly to maternal morbidity and mortality. For children, health consequences include premature births, LBW infection. Now, the government of India has taken a national Iron Plus initiative, and this is why prevalence of anemia is very high. Various efforts were already being taken to reduce anemia. Comprehensive plan of action to combat this problem has been missing. Some critical age group who were missing, like women in reproductive age group. All aspects of anemia were not being addressed. Anemia associated with malaria. Effective efforts were not taken to incentivize the administration and compliance, and there was no basically robust monitoring system. So this is what the life cycle approach is, that we start with the children 5 to 10 years, adolescent health 10 to 19 years, pregnant women and lactating women, and then non-pregnant, non-lactating women. Prophylactic IFS supplementation across all age groups is actually given. Under this NIPI strategy, we are covering all urban, rural, tribal areas. Life cycle approach, five life stages are covered, both preventive and curative aspects. Preventing consumption of IFA, syrup tablets, and albendazole under direct supervision of ASHA. Curative therapeutic treatment for severe anemia as per protocol at FRU and district hospital. Screening of target groups and referral. Non-pregnant, non-lactating, reproductive age group also added. 400 microgram folic acid tablet for prenatal age. Information and counseling for improving dietary intake and for taking action for prevention of intestinal worm infestation. So this is what various like maternal health is taking care of pregnant and lactating, child health, all age group except adolescent, and there is another division, adolescent health division, which takes care of the adolescent. Regarding this is taken by the health and family welfare. We are actually taking education department, women and child development, other stakeholders like medical college for research, and of course procurement division and SRC and etc. Networking with other stakeholders to work together to address the challenge of anemia. Now, if we go by the age group regarding the 60 months, we have 1 ml IFA syrup, 20 milligram elemental iron plus 100 microgram folic acid. And then the regime is bi-weekly we are giving, and of course biannual deworming for children above 12 months and above. The service delivery is through the ASHA inclusion in maternal, basically MCP card, which is the Mother and Child Protection Card, which has been jointly developed by Health as well as WCB. 5 to 10 years children, 1 tablet, 40 milligram elemental iron plus 400 microgram folic acid, and again weekly plus biannual deworming. And in this group, we in schools through teachers, for out of school children through Anganwadi centers, and of course mobilization of ASHAs. In 10 to 19 years, this will be actually covered by my another colleague, but I will just mention about 1 tablet, actually 100 elemental iron plus 500 microgram folic acid, and weekly it is being given biannual deworming in schools through teachers, or out of school through Anganwadi center, and of course ASHA's mobilization for mobilization. Pregnant and lactating women, 100 milligram elemental iron plus 500 microgram folic acid. 1 tablet. It was earlier given only 100 tablets. Now we have increased to basically after first semester to the entire period, and postnatal also. So that is 6 months antenatal and 6 months postnatal. That covers the entire period for 180. Means basically for 1 year. And for prophylactic we are giving 180, and if she is anemic, she has to take 360 tablets. 1 tablet for 180 days starting after first trimester at 14 to 16 weeks of gestation, to be repeated for 180 days postpartum also. And the service delivery is through ANC, ANM, ASHA, and inclusion in maternal child, mother-child protection card. Non-pregnant, non-lactating, 1 tablet again, 100 elemental iron plus 500 microgram of folic acid and 400 micro folic acid tablets. Weekly IFA throughout the reproductive period, and 1 folic acid tablet daily for 12 weeks once pregnancy is detected. Through ASHAs during house visit for contraceptive distribution. They can use it. This is key implementation points in children between 6 months to 5 years. We have bi-weekly 1 ml IFA syrup, 100 doses per child per year, and ASHA and mother caregivers are basically taking care of that. Then we have biannual deworming by ANM and ASHAs as per deworming protocol, August and February the months. Then key implementation points, children between 6 months to 5 years, implementation is liquid formulation in bottle of 100 ml each. 1 ml is 20 milligram of elemental iron plus 100 microgram of folic acid, and frequency is bi-weekly throughout the period of 6 to 60 months of age. Approximately 100 doses per child per year is given. Other specification, bottle should have an auto dispenser so that 1 ml of syrup will be dispensed at one time. Key implementation points again for 6 months to 5 years. That is twice a week, 1 ml, 8 or 10 doses per month for 4 or 5 weeks a month. child should receive Wi-Fi supplements on fixed days, that is Monday and Thursdays. Platform of VHND, that is Village Health and Nutrition Day, is used as once a month, and for counseling. Village level micro plan for Asha business to be prepared, and Asha would give IFS syrup bottles to mothers for safe storage and to lessen the logistic burden of carrying bottles around. IFS syrup, as per prescribed doses, will be administered under direct supervision of Asha only. For age group of 5 to 10 years, weekly, child would receive around 1 tablet IFA, 40 milligram iron, and 400 microgram folic acid on fixed days, 4 or 5 doses a month. And the teacher of school would be utilized through involvement of teachers. For out of school, Anganwadi center may be utilized, and Asha should be incentivized to undertake this activity. Village level micro plan will be prepared by Ashas. This is regarding deworming. The children 12 months and above should be dewormed biannually between August and February, and children between 1 to 2 years will be provided half tablet of albendazole, and children of 2 years and above will have 1 tablet of albendazole. Of course, IC, BCC, dietary diversification should be encouraged during nutritional counseling sessions on VHND for consumption of micronutrient-rich foods like dark green leafy vegetables, lentils, and locally available vitamin C-rich fruits using IPC and mass medication, and awareness about iron enhancers and inhibitors to mothers and caregivers and community as a whole. For pregnant and lactating mothers, this I have already enumerated. The provision of IFA tablet will be basically done through routine antenatal visits at subcenter, PSC, CSC, and of course nutritional counseling and ASHA to ensure provision of IFA supplements to pregnant women who are not able to come for regular antenatal check-up through home visits. This is regarding the woman reproductive age, which weekly IFA tablet is given, 100 milligram elemental iron, 500 microgram folic acid, albendazole for biannual deworming for Hillman's control. All non-pregnant, non-lactating women in the reproductive age group in the pre-conception period and up to first trimester of pregnancy are advised to have 400 microgram of folic acid tablet to reduce the incidence of neural defects in the fetus. And ASHA may distribute the IFA supplements to women in reproductive age group during doorstep distribution of contraceptives. Again, the operational plan, which is that nodal officers are designated at Ministry of Health and Family Health, states and districts for National Iron Plus Initiative for proper coordination. Regular review meeting in the states with all stakeholders to sensitize and orient and prepare plan of action. Procurement IFA tablets, syrup dispenser, albendazole, folic acid, IV iron sucrose are budgeted under PIP, and we are actually giving to the various states in this. And dedicated IC budget for National Iron Plus Initiative activities are also budgeted in the PIP, and we are sanctioning them. Provision for MIS and monitoring and evaluation, HR, innovation also budgeted under PIP, which we are supporting. Training and capacity building also an integral part of the program and is also budgeted in the PIP. And monitoring and supervision of the program also being done through regular field visits, and also we have developed a 5x5 matrix, basically through which it's a management tool, which basically helps in by the mission directors and principal health secretaries to monitor the program. This is what 5x5 matrix looks like. This is basically for entire RMNCHA basically component. Like in maternal health, one of the important component is detect high-risk pregnancy and line listing, including severely anemic mothers, and ensure appropriate management. In newborn health, it is early initiation and exclusive breastfeeding, home-based newborn care through ASHAs, and complementary in child health, complementary feeding, IFS supplementation, focus on nutrition, diarrhea management at community level using ORS and zinc, management of pneumonia, full immunization coverage, and of course in adolescent health, you have rollout of National Iron Plus Initiative, including weekly iron implementation. And we have health system strengthening and cross-cutting information also. Thank you very much.
Thank you, Dr. Baswar, for your overview of the government initiative, National Plus Initiative using health cycle approach. I now invite Dr. Sushma Dureja, Deputy Commissioner, Department of Health and Family Welfare to give a lecture on weekly iron and folic acid supplementation program.
Good morning. At the outset, let me say that I'm happy to be here to present the program which I'm steering at the ministry. It's weekly iron folic acid supplementation program, that is WIPS, for supplementing iron for the adolescent boys and girls. In the next few minutes, I'll be talking about, after the few introductory slides, I'll be talking about the implementation of the WIPS, how it's being done, what are the challenges, and how we can overcome together those challenges and bring about the desired results. As it has been talked since morning, nutritional anemia is a major public health problem in India and primarily due to iron deficiency. We all know about it. These statistics, these figures have already been talked about since morning. 30% of adolescent boys and 56% of adolescent girls in the age group of 15 to 19, as per the NFH's 3 studies, are the age group under focus in this. Anemia, as we all know, is the deficiency of hemoglobin. Among the other nutritional deficiencies like folate, B12, vitamin is the iron deficiency, which is the most common. Then the chronic infections, parasitic infections, then hemoglobin synthesis disorders, they all contribute to anemia. Causes of anemia have already been discussed in plenty since morning. I'll not be talking about it again. The one thing that I want to stress here is the poor iron stores from infancy, childhood deficiencies, teenage pregnancy, repeated pregnancies with less than 2-year interval, and poor environmental sanitation that has been talked about in the morning. This classification by WHO, we are all aware of. These slides. Clinical features I need not enumerate again. Consequences we have talked about in the morning. Coming to anemia in adolescents. As we all understand, adolescence is a period of transition from childhood to adulthood, period of growth, both physical and mental. With 253 million adolescents in India, which constitute more than 21% of our population, the highest across the globe. And as I just said, more than 50% of the girls, adolescent girls, 56% to be precise, and about 1/3 of the adolescent boys are anemic. If you look at this, what are the reasons for anemia in adolescents? First is the decreased iron intake because of the various dietary habits, food fats, and malabsorption that may be happening. Then increased iron requirement during this period of rapid growth because of the skeletal growth, muscular growth, increase in the height, weight, the iron requirement is increased. Then increased loss of iron. Worm infestation in both the genders and menstruation in girls again aggravates the problem of anemia in adolescents. As a result, we have a huge percentage and a very big absolute number of anemic adolescents in our country. As we are all very well aware of the intergenerational impact of the anemia. Pregnant woman with anemia gives birth to a baby with low iron hemoglobin levels, which, if remains uncorrected in infancy and childhood, leads to an adolescent with low iron and hemoglobin levels, and menstrual blood loss in girls further complicates the situation. And this adolescent enters reproductive age group with low iron stores. As has been talked about by previous speaker, NIPI, National Iron Plus Initiative, is the initiative by the Ministry of Health and Family Welfare to tackle this issue of nutritional anemia or iron deficiency anemia at all stages of life cycle, ranging from 6 months of age to 19 years, and then women of reproductive age group, as well as the pregnant and lactating women. I'll be talking about WIPS program, that is the weekly iron folic acid supplementation program meant for adolescent boys and girls. It covers adolescent girls and boys enrolled in government aided and municipal schools from 6th to 12th class. We are covering from 6th to 12th irrespective of the age, which more or less corresponds with 10 to 19 years of age.
and out of school adolescent girls. In this program, we are not covering out of school adolescent boys because of various reasons, because of their non-availability for consumption of these tablets. What are the four strategies or four arms of the intervention that we are adopting? Is the administration of weekly iron folic acid supplementation, that is the IFA tablet. It's a supervised injection. The two platforms that we are using are the schools and the Anganwadi centers. It's the teachers and the Anganwadi workers at these places who are responsible to ensure that all adolescents across the country consume this tablet of IFA. It's a blue tablet and coated tablet which has been selected for the program that is consumed by all the adolescents as a fixed date approach. Every state has a different date that they have decided there is a consumption of the tablet if some of the child is not feeling well, or it's a voluntary. Let me tell you, it's not a compulsory thing. It's the advocacy, it's the awareness generation about the program or about the importance of IFA consumption that has to be stressed upon, and it's a voluntary process. And the adolescent, the child is supposed to have this tablet in the school after the meals and with proper instructions which have been issued to those children with so as to ensure better compliance and low fallout rates. And by annual deworming twice a year, then information and counseling about the right type of food, the consumption of high iron-rich food, and about the dietary requirements that the adolescent must have. And last but not the least is screening of the target groups. It's not these IFA tablets which are being given on a weekly basis are just prophylactic doses. At the same time, we are required to look for the moderately and severely anemic children and refer them to the appropriate places, appropriate health facilities for further management of those conditions. It may not be possible for the school teachers moderate to and severe anemia. They can have a look at the nails, at the tongue, and they can have a fair idea about it. But it's again the responsibility partially comes on the RBSK teams which are coming to these schools for the detection of these cases. For the implementation of the program, as I said, we are using the platforms of the school and the Anganwadi centers for the implementation of the program. That means we need to have a very close collaboration, very close coordination with the other two stakeholder ministries, that is the HRD, Human Resource Development, and WCT Ministry for the implementation of the program, because it's the teachers and the Anganwadi workers who are responsible for the implementation of this program. Health Ministry is responsible for the technical guidelines, procurement of the IFA, and vendors on tablets, other formats, trainings, providing the IC material, while the HR schools and the Anganwadis act as the center for the implementation of the program. What we are covering right now is the 8.5 crores school-going adolescent boys and girls, 2.3 crores out-of-school adolescent girls, and 10.8 crore beneficiaries. Is a very huge number, probably the largest number across the globe which is being covered in under any nutrition supplementation program. The school-based approach is, as I said, is the education department which converges with the health department for the implementation of the program. The requirement for the supplies is put up by the schools. They, depending on the number of students in the school, they estimate the requirement, estimate the IFA supplies, which is passed on to the block and the district education officer. From there, it is passed on to the district health department. Procurement is done by the health department. As I said, the health is responsible for the procurement, and the supplies then run from the health to the education department at the district level. And at the district level, they change hands to the education department and are passed on to the last pole, that is the schools for the for being given to the adolescents. Similarly, for out-of-school girls, it is through the Anganwadi centers that the requirement is placed to the health department and the supplies reach the end point for the administration. It's, as I said, it's a very big program covering 11.3 crore adolescents across the country. So there are challenges also allowed in this program. There are issues of supply chain,
convergence at all levels which is required at the national level, at the state level, district level, and even at the grassroots level where the teachers and the Anganwadi workers have to work in very close coordination with the health department. Awareness generation remains a huge task to make the community aware of the fact of such high incidence of anemia, that their child could also be anemic, could poor performance in the school, or slow growth could be the reasons for could be because of the anemia. And there is need for a good dietary habits and the need to have this IFS supplementation. Lot of awareness generation activities keep going all the times. A lot of IC material has been prepared at the central level, which has been shared to the state. Plus, majority of the states have developed their own IC material to talk about the good dietary habit, need for healthy, balanced diet, need for rich iron-rich food, as has been talked about the previous speakers. It's not only the IFA tablet that will do the wonders. It's the total dietary habits which need to be taken care of. The need for prevention of worm infestation, use of slippers, use of chappals is a very simple intervention to prevent worm infestation and hence anemia. All these awareness generation activities, or what we call health nutrition health education, that packages are being developed with the help of UNICEF, and that will be distributed to the schools for conveying it to the students studying in the schools as well as their parents for the better use. Then there are challenges about the reporting mechanism, though the program may be going on very well in some of the states, some of the districts, but because of the convergence issues or because of the cooperation from the other departments, they could be reporting mechanisms. Emergency response system being a public health program, we have to be very careful about it, though we all understand and very well know IFA is the most benign medicine one can think of, but being a public health program, we have to take into consideration this all emergency response system. If somebody is one of the beneficiaries has any type of side effect that must be taken care of immediately, all those things, and the supportive supervision. The 2012, we have the countrywide implementation of this WIPS program, except 1 or 2 states which are not yet been able to do it. So this is one of the campaign that we have come up, Solid Bano India. And recently in December 2015, we had the presence of UNICEF Goodwill Ambassador Priyanka Chopra to talk about the IFA tablet. We had a function, and this is a small video it runs. Oh. Let me wait for a second if this video works, otherwise it stops. This one. We are putting it, what I want to say.
1 out of 3 boys. Did you know that in India, 1 out of 2 girls and 1 out of 3 boys live? Did you know that in India, 1 out of 2 girls and 1 out of 3 boys live?
Anyway, what I want to say, we are putting in all our best efforts to implement the program as well as to bring among the community about the need, about the anemia, presence of anemia, the importance of taking care of this anemia, and how do we go about it. This is the latest we have added to our work.
For talking to us about the WIPS program that addresses anemia during the growing years of adolescence. And this youth program requires integration of health education and HIV policy. So, moving ahead with the agenda, I now invite Dr. N. Raghunath, Scientist D from NIM Hyderabad, to talk to us about level 45 salt emissions.
Good morning, everybody. Myself, I thank TIFAC and the organizers for giving me this opportunity to share with you what NN has been doing with reference to combating iron as well as iron deficiency. This is particular reference to NNDFS, which what has been initiated in the late 1960s and has been going on beyond till date. So this is the background development of IFS. So food fortification, as we know, is one of the most cost-effective ways to make up the deficient nutrients. Fortifying food with various nutrients has been invoked from the 1920s onwards in Western countries and other countries, and this benefits have been shown. And multiple micronutrient enrichment of rice fortified with these things have been derived using hot or cold extrusion technology to produce micronutrient kernel of rice. And in this context, why salt? Salt, next to water, salt is the most universally consumed by all irrespective of their economic level, consumed approximately the same level throughout the year by normal population. So very low potential for excessive intake, and moreover salt production is limited to few centers. It's an ideal vehicle for iron and iodine fortification, some studies have shown that. And with the advent of universal iodization of salt and making iodized salt compulsory consumption mandatory, it necessitated the development of DFS or the double fortified salt. So when we introduce iron and iodine through DFS, it will be ingested at a uniform dosage through the year. Of course, I don't want to go into the details of iron deficiency. Senior was already Dr. Prema and others have already spoken about this. And the strategies to control iron deficiency could be promoting the consumption of foods rich in iron, sensitizing the population for the iron deficiency and its consequences, and increasing the awareness. Supplementation of folic tablets, of course, to this group has not been successful due to various reasons, including logistics. And iron fortified salt was one of the strategies which NIM did a lot of work way back in the late 60s and early 70s. It has been continued till the development of APSO4 recipe based formula, and it has been tried out in multi-sensitive efficacy study, and its efficiency has been proved. Similarly, iron deficiency is a preventable leading cause of mental disability throughout the world, and they continue to be a public health problem not only in the sub-Himalayan belt, which was earlier thought of, but also in the peninsular region of the country, and calls for immediate action. Since no food is rich in iodine, we have to look for sources. Only we get iodine through some of the food material, mostly through water, and it's also required, especially in endemic areas. So iodine salt was introduced some time back, and then also contributed significantly to the development of iodine salt formula in both potassium iodide and potassium iodide using various carbonate stabilizers as listed here. And then now coming to DFS, so that the government made it mandatory that all edible salt in the country should be fortified with iodine. So one should not ask people to consume two different types of salts, one for iodine, one for iodine. So we have to develop a strategy where both iron and iodine would be given to the same salt. So when I started working on this formulation using the common salt, not iodine salt, our initial efforts were starting with common salts using sodium hexametaphosphate 1%, APSO4, and then KiO3 at 0.067% level. And later, when the iodine salt became universally available and it was mandatory made mandatory for consumption, so we could get refined iodine salt. Now the latest technology what we are telling is to take refined iodine salt and make it to IS 724 standards, but we should be made without use of PFC because it interferes in iodine stability. And then mix it with sodium hexametaphosphate as stabilizer and APSO4 at 0.5% level, and you get the NADFS. It's a simple dry mixing technology which should be done on a batch mixing process, condition mixing process. And now recently, DFS, not of course, not necessarily NADFS, DFS has been given IS number, BIS number, IS 16232-2014. So, with reference to this technology, large scale production has been tried with NN formula in several companies. I am presenting the data. This is just in this what needs to be done, or what are the type of raw material that is required for making DFS, NIDFS, and how simple the technology is. The same thing is shown here. It involves a simple dry mixing method. Expensive measures or equipment are needed. It can be a batch mixing process or a continuous dry mixing process. Both are feasible if this one. And having said about the technology, how it was developed. So what is NIDFS? NIDFS is a professional therapeutic measure something that has to be consumed daily basis and throughout one's life course. It supplies 1/3 RD of iron when you consume at the rate of 10 grams, average 10 grams of salt per day DFS. you'll be getting 1/3 of RD of iron and 1 full RD of iodine. This is because of the various limitations in the diet intakes. Having developed this formula, then I wanted to see whether the iron and iodine, which are present in the salt, are stable or not. If so, under different conditions for how long. The stability studies have been done both with iron and iodine for different types of storage conditions. They have been shown to be stable for almost like 15 months iron and out of iodine up to 30 ppm in 15 months, indicating that both iron and iodine in the NIDFS formula was stable. And then after developing this, wanted to see what is the effect of addition of DFS in case of iodine salt or common salt. Will it affect the flavor, texture, acceptability of food source? Several types of food source tested using the DFS in case of iodine salt, and we found that acceptability was not affected as compared to iodine salt 4 to 5, the result was 4.125. And having seen that, we want to see what is the bioavailability. Is it because you have iron and iodine, is it bioavailable? So further the studies were done both in humans as well as in experimental animals, and in both the cases it was shown that iron bioavailability was, if not more, at least equal to that available from the fact was almost twice. Iron absorption was not different between the iodine salt and double fortified salt, indicating that both iron and iodine are from this NIDFS formula. Then, since it is supposed to be consumed over the course of life, so is it going to produce any toxicity? So the safety of the DFS was studied both in experimental animal models and then the human studies. No change was observed in the bone integrity, histopathology of other tissues. No impact in calcium phosphate balance, etc. Calcium phosphate homeostasis was not observed in children who were consumed for 2 years. No residual side effect, allergy or toxicity over 2 years of consumption of DFS, and 100% compliance was observed in all these studies. Then what is the impact? Okay, you have shown all this biometric. Is it having an impact on the prevalence of anemia or iodine deficiency? It was indeed shown that over the course of time, the DFS was consumed, the prevalence of iodine came down from 28 to 14%, and simultaneously urinary iodine excretion increased significantly. And similar observations with impact of anemia prevalence came down both in the rural and urban conditions before and after treatment with DFS. Now, having done all this, so what is the cost of DFS? How much extra money you have to spend for buying this DFS? So it was calculated from current, it was calculated a couple of years back. So if you calculate the amount of chemicals that needed for double fortification powder, it works out about 20 rupees per kg. Considering that iodine salt is selling at around 16 to 17 rupees per kg, maximum of 3 rupees per kg extra spending. And if you consume an average consumption of 10 grams salt per head per day, the additional cost of DFS over the iodine salt will work out to less than 5 paise per head per day. So that way it is not going to cost so much for consumption of double fortified salt. China has developed the technology for double fortified salt, but also developed simple fluid kits to test the iron and iodine content of the double fortified salt, so that one need not have to go to a lab to see whether it is present or not. So the simple kits have been developed. The papers have been published. I am not going to details of this. We have got kits for both iron testing as well as iodine testing. Then, having developed the technology, it has to be taken up by the manufacturers. So what has MIM done towards this? So we request the manufacturers to approach an with an intent to produce DFS. Then we ask them to, they will be given initial advice to meet what are the conditions. So once we go there and satisfy that they have got the equipment prescribed, then they sign the MOU with MIM for a transfer of technology, which is free of cost, and they do the trial production of DFS in their factory under supervision of MIM staff. And once the successful trial production is done, so that they are on the road to manufacture the DFS. So and also they have been advised to test iron and iodine content in each batch, and a lot of the DFS that they produce, not only in their own lab, but also send it to MIM for testing and confirming the results. And finally, they should also get a BA certification for the DFS that they are producing, so that the quality will be assured. And by this way, we have so far about 20 companies who have signed MOU with MIM for production of DFS, and out of which 13 of them have already carried out the trial production successfully and are currently manufacturing DFS. And this is the installed capacity. What is the installed capacity of DFS by these companies? According to what their own statements, it comes about 5 lakh tons roughly. So 0.5 million tons. Considering that iodine salt in this country consumes about 6 million tons per annum. So this 0.5 million tons is low, way below. So we need to increase the capacity. Now, I don't say that only NIDFS, any other plants also could be considered. So there is tremendous need to improve the production capacity of DFS in this country. If at all we need to meet the challenge. And these are the different brands of Gen9 DFS produced by different companies. And the quality of the DFS produced by one of the companies has been certified by Dr. Patel, earlier working games. And what is the impact? Has there been any evaluation of the impact of NIDFS in any field studies? There are some studies conducted in MS University of Baroda, so where they showed both in the children and also in the mothers, they showed that the bioavailability of iron was good, and then there was increase in hemoglobin and all other things are given here. Supplementation of DFS operation can positively impact the health status. That's what they concluded. And another study by Jan Kalyan Medical Society in Gujarat has also shown hemoglobin increased. And NIDFS has been used by Chhattisgarh government, has been supplementing under ICDS scheme, has been giving 0.5 kg of NIDFS to each of the ICDS beneficiary for more than 5 years now. And the report of the working group on this one showed that the DWCD, Department of Women and Child Development, Government of Chhattisgarh, has been providing 500 grams of DFS. NFHS clearly demonstrated reduced malnutrition and anemia levels in Chhattisgarh population, and the group strongly recommended that DFS should be adopted and utilized in the country. Following this kind of favorable results, in 2011, on recommendation of ICMR, Ministry of Women and Child Development directed all the state governments to utilize DFS where available in supplementary feeding programs under SDS, and also HRD Ministry directed that all the midday meals programs wherever they are implemented in the country, they should use DFS, iodine salt which they are using. And recently, I will add that FSSI, which is the standard authority, earlier it was NIN DFS, which is based on FSO4 SHMP. The FSSI has also permitted use of encapsulated ferrous fumarate, which is a main ingredient of the MI formula of the double fortified salt. It has been allowed in the manufacture of DFS. This has come in the Gazette notification of 2014. And Government of India is currently in the process of bringing about legislation making the mandatory use of DFS in all government feeding programs to start with, and probably to general public at later date. Having done all this, what has NIN done to make sure that the quality of the DFS is good of all the government state? So NIN has issued advisories from time to time, what type of what should be the minimum criteria the company should meet before they can buy salt from them. I'm not going to details of all those things due to shortage of time. So these things have all been properly fixed. And the National Innovation Foundation has shown, has given this official certificate, and this NIN DFS is just given, whatever was focused. So here is a product developed by NIN, made in India. Since the government is saying make in India, here is a product which was developed and made in India, so now should make in India in bulk. Not only NIN DFS, any DFS formula, so that we'll make the Bharat Swasth Bharat by improving the iron status of the population.
Thank you, Dr. Rajina, for highlighting this important root cause technology which is made in India, and also highlighting the importance of increasing its production to meet the demands. We now invite Dr. Madhavan Nair to talk on bioavailability of nutrients.
Good morning to all. At the outset, I would like to thank the Tifac for inviting me to present the work we have been doing it for the last maybe 20 years, especially my team. We have been passionately involved in developing technologies for controlling. I think from controlling we have to use the term immediately. Eliminating anemia from our country. I am trying to take you to a different approach the approach of increasing bioavailability of iron from diet, not only diet, from the fortified foods also. Because one of the important things you should understand is that you should have sufficient store to maintain hemoglobin levels. And we all know that females have very limited iron store. Normally it's absent or very limited iron store. So it is very important to establish the store in the early stages of life so that the individual is able to sustain hemoglobin, the normal hemoglobin. And there have been discussions about the fetus weight and the hemoglobin. And there have been studies from NIN, early 1970s, showing that the total iron content and the fetal weight are linear. I am creating the RDA for iron, and you look at that highlighted portion, which is established. That is very important because at the time of pregnancy or later, there is no allowance given for establishing this store. So during adolescence, at least from the age of 4 years to 16 years, there is an allowance. About 20% of your absorbed iron should be getting into the body and getting stored in the liver and other storage organs. Without that, you won't be able to maintain hemoglobin levels. And what normally you require is, especially I'm talking about the females, around 1.2 to 1.3 milligrams of absorbed iron. And that should provide that much. And only during pregnancy you can see it goes to more than 3. That's what the second and third trimester of pregnancy. And during that period only we normally pump lot of iron and try to maintain the hemoglobin. We never consider the stool. Look at this time trend in iron intake in adolescent girls. It's always below the recommended allowance of around 20 to 30 milligrams. So there is no way we can actually achieve that 1 milligram without increasing the iron content. That's one concept, and also increasing the bioavailability. Because when we were deriving the RDA, we considered diet with an absorption of 5%. That's the minimum absorption. Is it possible to have our diet at that level of absorption? It's possible only provided you have about 20 milligrams of ascorbic acid present in the diet. That's possible only through Dr. Taiwan saying you should have a adequate amount of leafy vegetables and fruits taken along with meat. Without that, you won't be able to achieve that 5% or above. So that's mandatory, and our recommendations are based on that. So you need to consider both increasing the iron content. Of course, you have strategies, fortification, one of the strategy, and taking iron tablet is another strategy, which is high doses. Now, this is a study we have done. There are 2 studies actually, and both done in India. One in Bangalore, other one is Hyderabad. Fortifying rice. You can see the highlighted portion that there is a real improvement in this store. Ferritin is actually a storage protein. We estimate that, and that is a reflection of how much iron stored in the body. You can see about 10 milligrams of iron, 10 microgram per liter of ferritin, which is equal to about around 80 milligrams stored. So per day it comes to what we have tabulated that around 20% of the absorbed iron. So there is a possibility of increasing the iron store provided you provide iron to the food. Also, iron absorption varies according to status. You can see males very low, it's around less than 5%, and also it is dependent on the food matrix. The nutrients in the we say ragi and the millets, the absorption is very, very poor because of the, the hard core, the outside shell, or it has a lot of polyphenols, which is again useful, but for correcting anti-deficiency anemia, it may not be a suitable one unless you increase the absorption from such diets. And in women, the percentage of absorption is around 8% or 10% if you are taking rice or wheat-based diet. So how we can increase the absorption? It's only possible through creating food synergy. How we can create food synergy? I will just show you. This is a food synergy. Adding a fruit increases ascorbic acid content in the food. It should be taken simultaneously with the diet. It should be part of the diet so that you increase the intake of vitamin C and thereby increasing the absorption. This is done in adolescent boys and girls, which clearly shows the absorption is tremendously increased to 100%. From 10% it is gone to 20%. That itself is actually a wonderful opportunity for us to address the anemia. So habitual diet with 100 grams of goat, which is a rich source of ascorbic acid. And this is done with the stabilizer dose. And I mean, it's a wonderful study we have done with collaboration from Baylor College of Medicine under the RO3 grant. This is another fruit. I mean, this not an Indian data, but I wanted to highlight that what are the fruits that actually, if you take it with your habitual meal, increases the absorption. This is papaya. You can see with the 70 milligram ascorbic acid taken with food, or 150 grams of papaya taken with maize, the absorption is almost, I think it's more than 100%. So let us think of strategies like this so that it will not only increase the bioavailability, and I mean it will actually increase the storage form of iron. Here you can see, in addition to papaya and guava, pineapple also is now supposed to increase the bioavailability. All fruits, but the effect is very, very different. These three fruits, because of the content is so high, 100 grams provides almost 200 milligrams of ascorbic acid, and it will overcome the inhibitory effect of all forms of inhibition. That is phytate, for example. This is a new concept which has been there, but we have selected few nutrients. Like is given listed there, there are 7 micronutrients added together, and it is a multiple micronutrient powder. And all of them are within the RDA limits. It's never high doses. And these micronutrients were supplied to all the Anganwadis. This is a study we did using cluster randomized placebo controlled double-blind study among 22 Anganwadi centers in Hyderabad, Nalgonda district actually. And this type of technology of fortification, not point of use fortification, by blending the micronutrient powder at 1 gram per child with the noon meal, what is given to the children, preschool children at Anganwadi centers. So this was given for 8 months, and you could see, I mean, the changes what you see in not only hemoglobin but also the iron status. That's the most important. So about almost, you can see 11.2 grams at baseline, which increased to 12 grams, and the ferritin, which is storage protein, about 10 microgram. That's about 80 milligrams iron absorption or iron store established during that period. Similarly, the other indicators, serum transfer in the circle again showing that there is a benefit of supplying this micronutrient powder. I mean, this has a cocktail. This mixes contains even ascorbic acid at 20 milligram. Maybe all this together increased bioavailability and is going with the food. And the cost of this supplement is only 0.32 rupees per child, that 32 paise per child per day. So there is a scope for scaling it up. And finally, there are many technologies available to increase the iron content. That is your national iron plus initiative, double fortified salt, what my colleague presented. Then you have fortified stable food rich flow. and the rice, biofortified staple complex is coming into the market, but it takes probably some more time. But not much is talked about as the diversification strategy. So we have no evidence to include that as an important strategy to increase the bioavailability so that anemia can be brought down faster or we can eliminate it faster. And of course the other one is WASH program, which has to be part of the, so it has to be holistic. I mean, all this has to be available and it should be implemented together. So building up of store is very, very important concept. And for which we have to increase the bioavailability and simple dietary diversification is possible. Scaling up of this strategy, the point of view fortification and multiple micronutrients is another strategy we should be seriously thinking about. DFS is, of course, it's already scaled up, and we should think of using various platforms like MDA and CDS. All this has to be used for introducing this. Thank you very much.
Thank you, Dr. Madhu Nair, for bringing this holistic approach to find solution to this important problem. We now come to the last lecture in this plenary session on treatment of anemia using Ayurvedic formulations. I invite Dr. Vaidya Balindu Prakash, Ayurveda consultant, to kindly give this last lecture.
Got the message? I'm so happy. I will put good food. All
Honorable Chairperson, panelists, previous speakers, ladies and gentlemen, I am thankful to the organizers, especially to Mr. Gautam Goswamiji, whom I contacted 4 days back on the advice of a panelist who asked me to try to present my work in this important meeting. So, I am a Ayurvedic physician, and my intervention to anemia is by default, as I was instrumental of conducting a study which was district nutrition project of ICMR in Dehradun district, where my organization, VCT Research Foundation, was one of the participating institutes. And there, while I came to know about anemia, I also came to know about internal, external quality assurance. And once I did it, and in my practice, because I'm a private practitioner, I found that one of my formulation, which has no iron, helping patients getting better. And after the intervention, when I did some objective parameters, I found they were getting hemoglobin gain. So I'm also happy to see here Professor Umesh Kapoor had a program advisory committee, and he was one of the experts. They came to Dehradun, and they helped us in designing the study, which I will show you today. So this is, you all know. So this is my first study, which we designed and carried in Dehradun, and this was sponsored by Department of Women and Child Welfare. As our own department, but got not very enthusiastic because the medicine I used, it is never mentioned in Ayurveda that it can put anemia. It is for something like Amlapika is an acid alkali disbalance, and Sitopalad is very well known for cough tablet. So there is no elementary iron. And this study which we did, it was in 600 subjects in non-reproductive age group people. And here, when we had 5 groups control iron, folic acid, and one Sushika Sitopaladi and one Ayurvedic iron, we found that non-iron Ayurvedic compound was most tolerated one. In, you have all the paper in your team today, Mr. Gautam Goswami circulated in the papers. So it has 22% side effect, while non-iron Ayurvedic medicine was very popular. It was published in Journal of Meteorology. I was encouraged to carry on cycling steady under the aegis of Ministry of Health and Family Welfare, Uttarakhand government. And we got funding by a leading allopathy company, Ipta Laboratories Limited, which has no interest commercially, but they were supporting our work on a place of ground. So it was an adolescent group, and here what we found that results are not the repeat, because the repeat result, it was a sustainable effect. Subject was treated for 90 days, and after that for 6 months there was nothing, and this showed effect with sustainability. And by this time, we had a committee in Uttarakhand government. This time we got partial funding by Uttarakhand government, and here we made a combination acid and this non-iron average formulation. And one was alone. And here you can see the results that the group which got both things, iron folic acid and non-iron average formulation, it showed the maximum improvement in but non-iron average preparation continue to show better results than iron folic acid. So this is also recently accepted for publication in the International Journal of Korea, and copies are used. And this product, which is a combination of two classical medicines, has been given a name Numex, and it is being produced under GMP certificate. Our formulation is very clear. Our observation that this non-iron acidic formulation has something to improve anemia. It is well tolerated. It helps in the absorption. So it is a new pathway, I can say. And recently, when our Prime Minister, who was chief guest in Global Ayurveda meet in Calicut, he also encouraged us by saying that we should bring traditional knowledge of Ayurveda by intervention with modern science and modern medicine. I'm glad that in this hall, we are sitting with scientists like Tifac, we are sitting with ICMR, and here is evidence, prima facie evidence, it talks about it. With this, we can design experimental and clinical study how to develop it. And there is a WHO guideline to develop traditional medicine that is reproducibility, safety, and efficacy. So this can bring, because we have many approaches, and when I was in PI of district nutrition project, I could see the magnitude of anemia, especially in the urban area of Dehradun, which is considered as a highly educated city, but the prevalence was quite high. So this can bring a scientific validation of Ayurveda, and it can also bring something innovation from our own traditional medicine. And I have a long list of acknowledgement. Dr. Kuteja is sitting here. He was right there for the district nutrition project till date. And many people, so it is endless. And lastly, I am thankful to the organizers for giving me this opportunity this morning. Thank you very much.
Thank you, Dr. Vaidya Prakash, for telling us about the Ayurvedic solution to the problem of anemia. I would now like to invite all our speakers on stage and our respected chairperson, Madam Dr. Soumya Swaminathan, for her concluding remarks. And I invite Dr. Prabhat Ranjan, ED, Tifac, to give away the mementos to the speakers.
नहीं जब भी देंगे
Imagine on the terrace. So at the end of this first session, what have we actually learned? We have a good idea now of the current status of and the state of the art of the knowledge about anemia. So Dr. Prema Ramachandran gave a very good, brief but
comprehensive outline and overview of the data that we have, and she also highlighted the fact that the anemia is directly linked to the diet and the lack of green leafy vegetables and fruits, and the fact that most of us consume less than 50% of the recommended dietary allowance of most of the micronutrients. I think NNMB surveys have clearly shown that. And the lower the socioeconomic group, the more the deficiency of micronutrients. Then we heard about the government programs from our friends from the ministry, and I think even yesterday or today our health minister is probably inaugurating the albendazole treatment day. Yesterday at Hyderabad. The National Deworming Day, and that's an important initiative. But the fact remains that despite this iron and folic acid intervention at all the different stages of life, why are we not having an impact as seen by our surveys? And so I think two things. One is we need to study the impact of the recently launched program also, so that we must put in place a surveillance system so that within a year we know whether the program is having the desired impact or not. And if not, I think simultaneously we need to start exploring reasons for it. Then we heard about the studies from NIN with the double fortified salt, and it's very encouraging to see how many manufacturers we have now. One issue, of course, is the cost. So, if you go to the market and an average housewife has to choose between a salt that weighs 16 kilos and 20 kilos, and she's aware that iodine, almost all the salt in the market is iodine fortified. This might actually influence the purchasing behavior. So even though we may think that 4 or 5 rupees is not a lot, but iron is a staple. So we have to see that the cost is also kept competitive, and also that it can be made available through the PDS. I think that will be the best way of ensuring uptake. I'm not sure if it is available now. Double fortified. We should make a push for that to be available through the PDS. I know that there are also discussions going on now on fortifying cereals like wheat, and wherever, I believe there are 12 states where wheat flour is given through the PDS rather than wheat grain. And in those places it may be possible for an iron supplementation to be done at the place where the flour is actually being, the flour mills. The rice fortification is obviously more complicated because of the technology needed to produce the things which has to be then mixed into rice. But wherever the studies have been done, like in Odisha, I think it has been shown that the uptake has been good, the acceptability is good, and the impact also, we saw the data from NIN, it does have an impact. And then we heard about the bioavailability of nutrients and the importance of the diet. Again, it comes back to what are you eating in combination with, and similarly with Ayurvedic preparation. I don't know whether it works in a similar way that ascorbic acid, vitamin C works when you take it along with iron. We saw the example of the guava. We need to look at your preparation to see what is it that is really making the iron in the diet gets absorbed. But it's doing the trick. So I think it comes back to actually having a balanced and nutritious diet. And that is what our traditional systems taught us, and that is what our traditional diets used to be. But they have all changed now. So one is that most of our population is dependent on what is available in the PDS. And if you only have rice and wheat available in the PDS, then that is what they are going to eat. And the second thing is, even those who can afford to buy from outside, do they know what is the right thing to be buying? People are spending more on fast foods, possibly, than on fruits and vegetables. And so it boils down to, I think, 3 or 4 key issues. If we have to have a bigger impact going forward than we've had in the last 30 years, I don't think we want to continue at the same pace. Because then again, after 20 years, we'll be discussing why we have not made a change in anemia. So we have to do research and intervention together, and it has to go quite rapidly. And I think all our national programs need to do that as well. I think every couple of years we need to take stock and look at the data. So that is where I think ICMR can work very closely with the Ministry of Health, with all the national programs actually, and have that evidence being fed into the changes in policy. So one is, how can we really make a massive campaign on, I think, awareness about nutritious food, nutritious diet. We have to also do advocacy with the state governments to expand the PDS basket. I think some states have done it. Karnataka is offering ragi. Odisha is planning to take the iron fortified rice into its PDS program. So I think doing advocacy at the state level also can have a big role. If they adopt the double fortified salt, for example, that I'm sure will have an impact. Second is, as I mentioned, so the awareness and how do we use our communication people, the media, and so on to really spread this through schools, through the Ashas and Anganwadi network. I think second is we have to link with the agricultural scientists of this country and the agricultural extension workers, because at the moment the two seem to be not very working closely together. So certainly I think the health ministry's programs and the agriculture ministry's programs are not coming together on the same platform, especially to do with horticulture. They have a lot of scope. They also have a lot of new varieties now of high iron and high zinc millets and wheat and rice varieties. So how do we promote those? And how do we use our agricultural extension network, which is very widespread, to encourage people to grow things in their backyard and to have kitchen gardens and so on. And the third, like I said, is what are the major gaps? Do we still need research to understand what are the factors that cause anemia in our population? Is it only the lack of iron in the diet? Because more and more that we are learning about, for example, the gut flora and the gut microbiome, we are realizing that the microbiome plays quite an important part in the health status of an individual. It's being now shown clearly that the microbiome of an obese person is very different from the gut microbiome of an undernourished person. It's also being shown now that children who grow up in insanitary conditions, like in a slum environment, compared to children from a higher socioeconomic group, you can see differences in inflammatory markers like fecal calprotectin from very early ages. Because Dr. Gagandeep Kang and others from CMC Vellore have shown that fecal calprotectin in infants, even by the age of 6 to 12 months, is 4 times higher in children living in slums compared to children from the doctors' families. So this early pro-inflammatory environment that happens because of exposure to a lot of infection in the end is also having a very big impact on the growth of the child, whether it's through impacting absorption or in some other way, but it is having an impact. And therefore, I think that the kind of interventions now of the albendazole being given twice a year definitely will have some impact, but whether it will be able to really get rid of this whole problem of enteric infections, we don't know. It will only have an impact on certain elements. And the high burden of infection like giardia and amoebiasis and so on that these children have, that's not going to be affected. So again, the albendazole program may or may not have the desired impact. So the sanitation and water issue again comes up as being extremely important. So the point was that the etiology of the chronic anemia in our country itself, though we know a large proportion is iron and folic acid deficiency, but what are all the other cofactors which really have an impact on that? And then finally, the traditional medicine. We saw one example of an Ayurvedic preparation which increases the. But again, I think the main thing about traditional medicine, especially Ayurveda, as like I said earlier, is the holistic approach to health and wellness. And promoting that is a good thing for everybody, I think, because we do want a healthy nation. And we have to promote good habits and discourage the harmful habits. So I hope that the panel discussion would address very concretely some ideas that can be taken forward. Because I think now we've got an overview of, we don't want to again repeat the problem statement. We have the problem statement. Let's put our heads together to find some doable solutions now. It could be new technologies, it could be in the area of advocacy and communication, and it could be more research. So if we can come out at the end, by the afternoon, with 2 or 3 key recommendations that we could take forward, then perhaps the science agencies can then work together. We can work with CSIR, DST, ICMR, and the Ministry of Health to test some of those interventions. So thank you again very much for this opportunity. I'd like to thank all the speakers this morning for being very precise to the point, keeping to time and illuminating us with their knowledge. Thank you.
Dr. Ranjan, kindly give a big
Yeah, thank you very much. And you want to meet him from my office also.
I got a request from them.
have tea break for about 10 minutes.
Did do.
You can request you to be back after 10 minutes for the panel discussion.
Yeah, please come back to class because we are running late. Thank you. He's been serving a long ground floor.
यहाँ पर देख लो यहाँ पर देख लो मैं इसके आगे फ्रेंड को बुलाते हैं किसी को मैंने एक्चुअली आपकी बैक आ गई सर
I request all the panelists to be here within 10 minutes. We'll start just within 10 minutes.
प्रेजेंटेशन जो है सब कॉपी कर लेना देखो कॉपी नेक्स्ट सेशन कर देते हैं अभी पता ना 10 मिनट बाद
कल लैपटॉप पे रहेगा
हाँ ये कौन यार यहाँ से देख के नहीं
आप तो रहेंगे
मैं ये कर रही हूँ मैं चाय पीता नहीं
ये हमारा
ऐसा लगता है छोड़ देता
यहीं पे छोड़ देते हैं
नहीं
ये तो अच्छा यहाँ पे लगा स्टेज पे
बैग आप लोगों के वहाँ पड़े हैं। आप कौन जा रहे हो? चाय पिए चाय। अरे यहाँ पे मुझे बहुत पड़े हैं। दो दिन आ जाओ छोटे में जाऊँगा।
मुकेश एक्सटेंशन बोर्ड लेकर
Kind attention please. There is curfew in room number 12, ground floor.
इधर बैठो फ्रंट में अब ठीक है ना है मतलब पर वो नहीं बताऊंगा
Kind attention please. There is curfew in comedy room number 12, ground floor.
है तो लेकिन वो इनका डॉक्टर चंद्रशेखर का उन्होंने इनको दिया होगा मैडम कह रही मैंने नोट तो उसमें है नहीं मेरे को मेल भी मेल तो कोई नहीं आई मेरे पास वो तो एक लाइन तो है सबके में हाँ
मैं अच्छा हो रख दे, चाहिए होगा यहीं पे चाहिए होगा, यहीं पे लगा के छोड़ देंगे, लगा के छोड़ दो। आपके बोर्ड से मिले तो इसमें दो ही में तो बोर्ड लगा देते। लगे आया
मैं लग गया था मुझसे ढंग से लग नहीं ना है पाजी लग गया पाजी मेरा किसका क्या कैमरा तानु शूट कर रहा है वो ठीक है ना जिंदगी में नहीं तो लगे तो जोर लग जाए करेक्ट कैमरे को चोट लगी तो वाला ठीक करा पाया है रोज मैं रोज गुरुद्वारे सैटरडे संडे में कोशिश करना सर्दियों में 15-20 बना 9 किलो तो बना मेरे बाकी दिन बिना नागा बाजी रह जाएगा सिंह पक्का అది దూజారు కరవాగా డ్రింక్ బోర్డు ఉందా నా पजामा चिपकेगा पजामा लेकिन पजामा नीचे लाला करो ना लाला करो तनख्वाह मिलेगा देखो सालों के ढांचे का तनख्वाह ऐसे ही अपना सच क्या गोस्वामी जी चिट्ठी क्यों लिख रहे थे अपरिचित आप ये पुराने चेहरे बहुत साल देखिए
Swati, ready?
Hello. Good afternoon. Welcome to our next session, the panel discussion. Our DG ma'am has already set the platform. What to discuss in the panel discussion. Broadly, we have grouped the several issues into 5 agenda for panel discussion. Whether the existing national program needs to be strengthened to create a significant impact on the civil society. What are the gaps still exist between the policies and the ground level execution? Strategies that are required to popularize the elimination of anemia movement, use of ICT, social media, etc. Development of rapid diagnostics for hemoglobin estimation, which is economical, accurate, and easy to operate. How traditional knowledge can be harnessed in this endeavor. With these issues, we would like to start the panel discussion. May I request all the panelists, Dr. Soumya Saminatham, who was supposed to moderate this session. She has an urgent meeting, she is left. Now may I request our Executive Director, Dr. Prabhat Ranjan, to moderate the session. Dr. Prabhat Ranjan, please. Dr. R.T. Pant, Director, and or Dr. Panwal, I don't know who is it? Please. Dr. Sandeep. Dr. Rajan, M.S. Rajan. Dr. Patel, Ketan Patel. He is there. Oh, unfortunately, he has some other assignment here left. Dr. Sharad Iyengar. Dr. Koteja. Dr. Chandrasekhar. Due to rescheduling of Honorable Minister's program, we have to cut short this panel discussion. We are having about 35 to 40 minutes. Because 1 o'clock, 1 o'clock we have to break for lunch. So my request, Executive Director Dr. Prabhat Ranjan to moderate now. Thank you.
Hello, yeah. Thank you very much for coming to this session. When I heard the first session, I was very happy, but at the same time, I'm very sad. We seem to have everything in place, but as young people say, we have not cracked the problem because we still, statistics are daunting, the numbers are daunting. So I think the task before this panel is really to focus on, from what we heard in the first session, where do we go forward from here? How do we tackle this problem, which is our grand challenge one, we identify Vision 2035. I would request panelists to very briefly, if they want to say something, one by one, we can go through around and then we can start some discussion on this. Dr. Sobhay was to handle this, so she was a better person to do this, but I am playing the role of a neutral person. so, but I was also part of the panel from ICT point of view. So I will request Dr. R.P. Pant to start a few comments. He's not yet. Dr. Sonwal.
Good afternoon. I am Dr. Panwal, working as a joint technical advisor in the Ministry of Women and Child Development and looking after nutrition and related issues. At present, our ministry is in process to design different tasks to eliminate malnutrition. And recent initiatives, just I will brief. First priority, our Honorable Minister was very much concerned to ban junk food. That junk food, we were in process to prepare the report and guidelines, and since it was not our mandate, but even though our deep concern was shared with Minister of Health and Family Welfare as well as Resource Development. With Minister of Human Resource Development, we requested them to ban junk food in the periphery of the schools of all government and non-government schools, and that all letters have been written to all chief secretaries to take up this issue with the concerned authorities. Secondly, we are in process to design the regulation and directives on food fortification because we are in process to universalize entire things, especially staple food, that is wheat flour atta, then oil, then milk, then salt, which are commonly used by the common person. And we have designated Dr. Longwa as the chairman of this committee. That one committee has been formulated, and his final report is in process to take shape, and very soon we'll be having stakeholders meeting, manufacturers as well as the policy makers of relevant and line ministries. That is our another venue we are going to target. Third, we have been disseminating this IEC campaign. We have developed various films through DABP and NFDC that to have a dissemination and awareness on malnutrition. We have developed various films on how to take diet, what kind of diet we should take, what kind of care, prenatal, postnatal, then pregnancy, everything. Even for adolescent girls also we have been targeted. And then all these films are on our media, and daily it is coming in the media. So these are the main highlights three. And besides this, ministry and in the context of Food and Nutrition Board, I will say the awareness program is in process and it is taking up. We have 43 field units network all over India, and through this fruits and vegetable training program, as Prema ma'am said, that more than 35% fruits and vegetable is going west, and we are showing that we are teaching techniques how to consume these fruits and vegetable in flood season to overcome from the vitamin and mineral deficiencies. Then secondly, training of trainers and orientation training courses for CDPO supervisors and all, even district magistrates we are involving to how to, what kind of training and what kind of nutrition we should take through training to the beneficiaries and to the officers working under them. This is also designed program. And beyond this, we are having monitoring of the Anganwadi centers because it was deliberated in morning also. Water quality is also very important rather than other parameters in eradication of malnutrition. So water, we are having consultation with Ministry of Drinking Water and Sanitation that very soon we will be drawing samples from Anganwadi centers and we will ensure that the water consumed by the beneficiaries in the Anganwadi center is very safe, hygienic, and because it is a root cause of various diseases. So this is just kind of update from my ministry, and very soon we will be in position to finalize the things, and we are expecting positive outcomes will be there, and it will definitely help to reduce malnutrition up to some extent.
Thank you very much. Now I request Dr. Sachdeva, who comes from Sitaram RPA Hospital, very close to Tifac. Both of the people run through that hospital. So, for brief comments.
Good afternoon. Let me start by making a few things clear on the basis of evidence. Most of it is published in a publication in European Journal of Clinical Nutrition. If you are interested, you can take the reference. Point number one, anemia is multifactorial in etiology, and the lowest common denominator is iron deficiency, but most of the people do not realize it, and ultimately when it filters to the policymakers or the politicians, at best if you give supervised iron tablet every day to children or women, you can take care of only 38 to 62% of anemia, or roughly half. This will vary from place to place. So the government has, we have been having decades of this iron supplementation program going on, and everyone keeps on asking why it's not improving. A point is that everything is not iron deficiency. Just keep that in mind while formulating policy. The government has now, Ministry of Health and Family Welfare, looked at the life cycle, which is a very important approach. We were involved in that. So they have come to, because of logistic reasons, giving bi-weekly tablets in a dose, saying that in effect that it will be absorbed and stored and not gone away. One thing which the government needs to recheck is, I'm not sure whether Dr. Sushma Dureja is here. They are using or were using enteric coated tablets. Very serious questions have been raised about the absorption of iron from enteric coated tablets. So we are spending a huge amount of sum. We better be sure that it's the correct formulation rather than the enteric coated tablets, or at least the concern should be taken away that it's not doing that. Second, despite giving this carefully supervised over this thing, one must carefully also look at whether low doses, say through fortification, continued throughout the year, are likely to be much more effective and safe rather than the intermittent. This is an experimental mode because it's quite possible that all the iron does not remain absorbed and contribute to it. So then what else is the rest of the half of the anemia? What about other micronutrients? We have other hematinic micronutrients, B12, and other things. In a carefully done systematic review, we did show and compare if we add other micronutrients. There's a paper here by Dr. Kuteja on B12. If at all, it will improve anemia by only 0.1 on an average of 0.2 grams per deciliter, which will just take care of an additional 3 to 5%, which depends on the other. So perhaps on a national scale, food would be a better priority rather than going about to looking at these things. Today is the deworming day. You might have seen so many advertisements in the newspapers, so many crore people. We did a systematic review published in BMJ and now recently in Cochrane. If you give prophylactic deworming going on continuously, a lot of money and logistics is being spent on that. It has almost negligible effect on anemia, not at all. It may have had an effect 30, 40 years back when worms infestation was so common, but not now. We need to take care of that. We do not want to spend excessive resources on these things. Another very important issue is subclinical inflammation or infection treatment, and that is intricately linked to poverty, water supply, sanitation, or infection. So unless and until, like Nag showed in these trials, you give fortified rice or whatever you give, creatine rice is used very little. The maximum effect is seen with condiments and with not in the usual ones. Salt is effective, but only by 0.3 grams. So the point I'm trying to make is, unless and until this background, this iron gets deposited in the body, it's not going to go into the marrow until and unless the subclinical infections are taken care of. A couple of more points if you want to just, I know it's important, but it's important from programmatic aspects. There are areas with malaria, Jharkhand, the infections which do need to be taken care of that. A lower, we have on paper a policy of milking the umbilical cord, which takes care of anemia, but that needs to be popularized much more so that the cord is not. And complementary feeding is one of the most vulnerable periods. The government has started it. It has to translate into the practice. Thank you.
Captain Dr. M.S. Rajan.
Just one thing.
Yes, sir.
I think I forgot a very main important thing. In some areas, hemoglobinopathies are a very important issue. Up to 6% of the population can have hemoglobinopathies. We do not have any mechanism to look for them, and that's where technology could help with hemoglobin estimation and hemoglobin health.
Good morning, everybody. I just want to run through some things. Today, we have discovered it's a deworming day. It should be a day or May Day for anemia. Most important things are, as I see in my village with 2.5 years of experience, 75% of women are anemic. That is because, one, I think government should come in with food fair for all, men and women, because we find ankylostoma duodenale is one of the very big problems we face. Number two, there is so much of polypharmacy. These patients, one really knows not what are the inter-drug reactions. Number three, chronic ailments as what is said by the panelists, tuberculosis, malaria, and now looking more to the west, we have got lots of diseases, milk allergy, food allergy, and whatnot. All these are stunting the absorbing villi, so leading to malabsorption. The other most important thing is, the factory of anemia is the bone marrow. The only one way to rejuvenate the bone marrow is by oxygenating the bone marrow. And the best way to oxygenate the bone marrow is through yoga. I've been doing yoga for 30 years. I've been paralyzed for the past 8 years, and the rich negative ions which enter the blood are able to rejuvenate the dwindling yoga. So the problem is multifactorial. Water at every point, wherever there are more than 1 lakh people, should be weekly checked for waterborne infections. The E. coli country. In Germany, UK, and Singapore, all of you know, many have joined. You can drink water from the streets, which you cannot even do it from the best of private hospitals. So these are to be tackled on a global level. Thank you.
Dr. Chetan Patel had to leave, so Dr. Sarad Iyengar is requesting you.
Thank you, Dr. Ranjan. My aim is not really to make a presentation, but just to focus on a few facets of anemia and linked health conditions that we have been discovering. I come from Rajasthan, from Udaipur. The southern part of Rajasthan happens to be a tribal belt. I'm part of a non-governmental organization that looks at training and research in the context of improving health of persons. And in these southern districts, you find that the health indicators are often the worst as compared to other parts of the state, and so are the nutritional indicators. I'm drawing on a few studies that we have done. We have looked at early postpartum maternal morbidity in an extremely large number of women delivering at our facilities and living in the community and delivering at home and elsewhere. We've looked at the consequences of maternal complications on women's lives within the first postpartum year, and we were part of a large trial to compare feeding regimes for managing severe, uncomplicated acute malnutrition. And at that time, we had the good fortune of also being able to measure weight and height and hemoglobin levels among the mothers of a large number of these children. So the major issues are, yes, there is a large burden of severe and moderate anemia. Now, this comes from a time when there were a certain number of home deliveries, they have declined, but 7.5% severe and about 45% moderate. We found this to be associated more with the tribal communities. They are the poorer people, they live in the more remote areas, they are up the hill where there is lack of water and poor quality of farming and land ownership. A little more with home delivery because the poorer people continue to deliver at home, and now most of them have come to the institutions. So we found that there is this large burden. It correlated with poor perinatal outcomes. So stillbirths, neonatal deaths, and even infant deaths correlated quite strongly with the level of anemia in the mother who had just delivered. I'm sorry, this has got distorted. I'll go ahead. But in the trial that we did on severe acute malnutrition, we found that mothers of children with SAM, over 75% of them had a BMI below 18.5. And then we had BMIs going right down to numbers like 9 and 8. So there's a significant degree of malnutrition among women who have malnourished children, and it was quite clearly pointing to this intergenerational transmission. High levels of anemia among the severely malnourished children at 16%, but surprisingly we did not get a whole lot of anemia among the mothers. So what is this pointing to? In an area where both health systems and ICDS is a bit dysfunctional, it appears that although we have an antenatal pregnancy anemia treatment program, we have a pregnancy anemia treatment program, we seem to forget all about anemia once a woman delivers. Once she goes home, that's it. If you measure hemoglobin at the time of delivery, you find a significant number of women going home with anemia. The numbers I gave you, 7% at the time of severe anemia and 45% moderate anemia was among women undergoing deliveries. And immediately after, and this is after the first 1 or 2 days when there are hemodynamic changes. Yet we do not look at this issue. It correlates with poor outcomes for mother and the infant. It correlates not only with mortality but also with poor performance by these women. They just move tired and exhausted to resume normal duties. It affects the income generation by that family, and that poverty therefore has negative consequences. I therefore feel that one of the major thrusts of the health agencies should be, given that Janani Suraksha Yojana has been one important achievement wherein large numbers of women are coming to institutions for delivery, that should be the opportunity to go and take a look at what is the level of anemia and what can be done over the first postpartum year. Now this is easily said rather than done. Even in the case of home-based, more importantly newborn care, you find that large numbers of ASHAs are not really making home visits, and if they make home visits, then they don't really provide neonatal care. And the net result is therefore neonatal mortality rate remains high, it's dropping a bit, but not because the ASHA is making home visits at scale, because she's not going there. And why does this seem to happen? Whether it is ICDS or the health agency, my experience, and I'm talking now from the ground level in villages and such regions of Rajasthan, supervision of home-based care, whether it is care about feeding or providing immunization or even home-based visits, is extremely poor. So facility-based interventions work, home-based interventions don't work so well. So until and unless we do a real rethink of how we supervise our village-based services, And unless we invest heavily in that supervision, and that heavy investment means mobility and the use of things like mobile technology, we're going to find that in these remote interior areas with high levels of dysfunctionality, absent teachers, absent Anganwadi workers, absent ashas, absent doctors, absent nurses, and just about everyone else, but attending very, very irregularly, we're going to find that the best of the interventions that we heard about in the morning don't seem to get on the ground. So we will need to really invest heavily. The second point I wish to make is that if a woman is very malnourished, you're going to have women with extremely low BMI. You can't just get them to normal hemoglobin levels and leave them malnourished. So unless their nutritional levels improve, and that's the function of poverty alleviation, the PDS, and other aspects that go well beyond ICDS and health, unless that is addressed, I simply wonder whether you're going to be able to, manage the anemia. And it's only when the women have the iron stores that the babies won't be born with poor iron stores, and this cycle will stop perpetuating. Thank you.
Yeah, and then I will request Dr. Professor to give his initial remarks.
Thank you. I think for panelists, organizers, they given 5 points to comment on. One is that whether existing program of government of India needs upgradation. Number 2, what are the gaps in the program? Number 3, what other technologies can be used to improve the anemia? Number 4, the diagnostic methods. And number 5, how to use the traditional knowledge. These are the 5 points that they give organizers to us. The first, I would say that when this program was launched in 1970, so we had adequate evidences that iron folic acid supplementation will improve the hemoglobin level and will bring down the prevalence of anemia. And therefore, not only in our country in 1970, but many more countries we launched this program. The first time in 1984-86, this program was evaluated, and it was found that the compliance of the iron folic acid tablet to pregnant women with 100 tablets including second and third trimester is very, very poor. Only 11% was the 100% compliance. So that indicates that there is no problem in the program. It is only that the compliance is not working. There were also other issues about the logistic of supply. There were small tablets, large tablets, and they were not reaching to the primary health center in time. And if they were reaching, there were expiry dates and all those things. These issues have been addressed again and again. In 92, we revised the program, and from 60 milligram iron, we made 100 milligram. But anemia prevalence is still very, very high. Then in 2007, again the program was modified, and then we included adolescents also. And then in 2011, Iron Plus program, we modified the doses for children also. The whole process we keep on doing, but the bottom line is that you see the compliance of the program is very, very poor. So Sachdeva has talked about our publication, which has come last month only. So we had a clinical trial, 2 arms, iron folic acid tablets in 1 arm, iron folic acid B12 in 2nd arm. Our results have indicated that even iron folic acid tablet, you see, is a supervised trial, weekly supplementation for the adolescent girl. It has indicated the prevalence of anemia has come down to 37%. It means if the iron folic acid tablet program, compliance is good, you see, you are bound to have good effect. 30-40% by this only is good enough. Other Dr. Nair has also shown, you see, the main thing is that the iron intake. When we are not taking iron, adequate iron, you see, we are bound to have a problem of anemia. And then other thing like Dr. Shah mentioned that BMI also. The protein is also required. So there are a lot of factors which put together that can improve the anemia status in our population. But I would say that what we are lacking is that the monitoring of the program at grassroots level, the accountability. This we have been discussed time and again, but we are still not focusing how to improve these things. What we are doing, survey and survey. A lot of surveys have recently been carried out and we spent crores of rupees, but we are not focusing on the implementation of the program. So unless we improve the implementation of the program, you see, we are not likely to get any result. The program is good, only we need to monitor and implement properly. Then with respect to other technologies, those things all are good. You see, we should not be very fussy. Long ago, when we launched this nutrition goals, National Nutrition Policy in '92, there is one school of thought that they say long-term strategy should be followed, no fortification. Get away with this type of thinking, you know. Anything which help to bring down the prevalence of anemia must be welcome. Till you reach to that long-term goal, you know, still 2 decades more past after launching the national nutrition policy, there is no improvement in the anemia prevalence. So therefore, all the other approaches, whether it's double fortified salt or other fortification of foods, all these approaches should simultaneously we should work out. So that overall effect you see, as Dr. Sadhya also mentioned, deworming it doesn't have much impact. And overall impact you see it will be good in coming years. And other thing I would like to say that like our trial, there is another trial done by Dr. Koteja in 2006. It has been published. He has also done supervised trial in schools, and there he has shown that 21% of anemia has been brought down by supervised trial. The program is implementation, and second thing I would say regarding traditional knowledge, that is there. You see, the Dr. Indra Chakrabarti has a lot of work on horticulture approach. So these approaches are very good, and we should follow that awareness. Everything DJ also mentioned about that. But with respect to programs, I would say it's implementation which need to be focused. Thank you.
Thank you, Dr. Koteja. Now, request Dr. Chandrasekhar to give his comments.
Yeah, good afternoon. I come from ICMR, and the primary job of ICMR is to promote biomedical research in the area of health. That is what we have been doing for many years, and that has resulted in the generation of lot of evidence which will help us to either understand the etiologenesis of anemia, the pathology, and the clinical manifestations, and possibly also how to combat anemia in children and women. Now, in the last 5 to 7 years, ICMR has taken a great leap in terms of generating this evidence into translating this evidence which can help people and the program at national levels and beyond. In that context, I want to say that we have been making all the efforts for doing some innovations which can supplement and can give a lot of support to the program, which will make it cost effective, which the people and the governments are able to afford. In this direction, we have developed some technologies in the area of anemia. Dr. Nair is here. He has developed some kits for estimation of ferritin, and he has also created a medium for which the blood samples can be taken at the field level, and we can be analyzed at the lab in a tertiary or at lab level. So these are the things which will help us to help the people in the communities as well as to generate the evidence for the program as to this use of these technologies which can be utilized to the utmost, and that is our endeavor in ICMR. And I would like to take this opportunity through you and your friends that these grants are now available in ICMR. Anybody who wants to have innovation in mind, something that is already there as a concept, to take it to the level of a bench and then translate it to use for the public is something that we would be very happy to be funding. Thank you so much.
Thank you, Dr. Chandrasekhar. I was asked to be the panel actually initially to focus on the ICT related aspects of this. Information and communication, I was professor for about 11 years. Now, what we found, I'm looking and hearing to all of you, the 3 aspects that I'm looking at. One is the awareness part is severely lacking. Like we talk about DHS level 45 salt. Personally, I was not aware of actually. Second part was the point that being made out is the monitoring at ground level. That is again something that I feel that the monitoring systems through ICT tools like mobile phone and so on could be tried out. And third part is the way we communicate to people has to change. That today we make films, like you said, ministry has films, but how many people actually watch those? The way we are getting information is changed. When we were launching technology within 2005, this was the issue that we were also discussing, that how do we disseminate information? And today, for example, social media is very important. There, if I put a film of even more than 5 seconds, probably nobody will look at it.
So we have short films,
yeah,
30 seconds to 1 minute, and that is just played in hospitals only. PSC, given rural hospitals, civil dispensaries, or super specialty hospitals in big cities also. There we have given these copies, and just they are playing for 1 minute or 1 minute. Scroll messages also we have. So I agree that people don't have time to see and to watch 15 minutes or 20 minutes, but our theme is to convey the message in a very short time.
No, what I'm saying that is okay, but we need to enhance that reach
Yeah.
in many ways. Two of my students actually they started a project called Menstrupedia to make women aware of menstruation. And they have done all kind of things, including developing comic books and all kind of things. They were from ICT background. And they took help of designers and so on. And they have, it's a major for the last, I think, was last year, 6-7 years. So I think I would let the floor be open for a few questions. We don't have too much time, but maybe about 5, 7, 8 minutes that we can spend on this. Any questions that we have from audience? While you're waiting for that, I have a question. There is a question. Yeah, please come. Go ahead. Yeah.
Sir, I'm Dr. Shalini Singh from ICMR. I'm working in maternal health area. I would like to ask the panelists two questions. One is like, do we need any other strategy for in diagnostics for in the community when we're doing this survey, so that hemoglobin is detected, the levels are detected correctly. And what are the strategies for severe anemia? Because we have to focus on severe anemia, and the program doesn't seem to have focused on that.
Anybody?
I think Dr. Shani, you raised a very important point, and here we should not confuse preventing anemia with treating anemia. What you are suggesting actually is an approach of selective treatment. If you get severe anemia or moderate anemia, your dosage requirements and the duration of therapy becomes pharmacological, whereas in prevention it's a different line altogether. So yes, I would strongly argue if there is possibility logistics, we should have the ability to get accurate hemoglobin levels, and if the person is not responding to this, to look at other important causes like hemoglobinopathies, which are in certain areas quite prevalent, like thalassemia minor, sickle cell anemia. That might be the reason which is not going on through testing. So yes, there is a role for simple technology for accurate hemoglobin estimation, and in a secondary stage for hemoglobin.
I'm talking about Tamil Nadu. Almost 65 to 70% of persons are amoebiasis infected. It's a very big problem. Silent, it restores in the liver and stays there forever and ever. Amen. So unless the burning problems of hookworm infection, that's number one. We have found hemoglobin as low as 4.4 grams. And amoebiasis, both are treated pari-passu. We may get a better result.
I think the questions are two different questions she asked, Dr. Shali. To answer to the first question about the estimation of hemoglobin, I think existing method of filter paper is good enough because you see the cost effect, it will cost only 1 rupee. And you see we have a lot of studies on stability which indicate that you see even if samples come that on filter paper within a month also, and we just keep at room temperature, it will not degrade. You only require telling that how to take 20 microgram blood and put it on whatever filter paper one. So this technology is good enough and very cost effective. And for the field study is good. The second part about severe anemia. I think severe anemia is the one issue which upon local and focal. Dr. Anger was making a presentation, he showed 3%. But in Rajasthan also, the annual health survey which has been done by Ministry of Health and Family Welfare. So we had done 1 lakh samples we analyzed at DMRC Jodhpur. And data with us, we analyzed those. And what we found that the 5 districts are tribal, 5 districts are tribal, severe anemia was around 5 to 6%. But no non-tribal, the severe anemia was 25%. So you see, I think we have to find out the reason. What Dr. Satyava has said that hemoglobinopathy. Normally hemoglobinopathy is more in the tribal area. But finding based on 1 lakh sample, you see is different. I think we need to address the issues, the causes of the severe anemia, which may be different in different locations, and then we need to address that. Another point which I would like to say is that we have been discussing, as he said, 4 gram, hemoglobin level is too low. Even you see the functional, people are working, I tell you. So we do not know that the values which we have fixed up, whether values are, you see, for our country also or not, that we have been discussing for a long time. WHO has not revised the severe anemia cutoff to 8 from 7 to 8 in 2011 document. That will indicate that more cases of severe anemia will be there when you have the 8. So I think these are the issues which we need more discussion. And thank you for asking those two questions.
Yeah, please go ahead.
Mr. Dr. A.K. Sarkar. Sir, you just mentioned that your systematic review on prophylactic deworming
Keep mic close to mouth.
systematic review
Right.
on deworming has shown that it affects negligibly. Then why is it that we are still celebrating the deworming day and the ministry people were here? How should we fill this gap so that the policy people are better informed about the evidence?
I think that's a very important question that you have asked, and I would have wished that they were here. We initially did a systematic review in DNK 10 years ago, which showed zero point 0.1 to zero point 0.2 grams per deciliter. After that, several trials were conducted, and there's a lot of international debate going on. The Cochrane review later on has showed there's no effect. If at all it is beneficial, going to be beneficial in those who are known to have worms, or in areas which have at least 70 odd percent of the prevalence of worm infestation, particularly hookworm. India currently in most of the areas is not in this situation. This is one viewpoint to which I subscribe, whereas the other, the deworming the world, people say that we are still at the same stage which we were 50 years ago. There's data from Vellore which has shown that from initial 84% odd in the community in the rural area, it came down to 50-60% published in IGMR, and now it's 20%. So one of the argument which is used to push this is we don't know our worm burden. It is continuing to be the same. It is expensive, very expensive to go ahead and do studies to determine the worm burden. It's much more cheaper to give two tablets. All right, go ahead and give it, but be clear about this that prophylactic deworming is not going to improve your hemoglobin, not going to improve the weight of the child, and not going to have an effect of make us retarded people as we are made to believe. So there is a lot of this thing. I believe I've been told that WHO is revisiting this issue in a guideline group meeting. Maybe some change may come in light of the new evidence, but do not believe the gospel truth that deworming will finish off our problems of India. So I can't take this decision. It's the ICMR, the Ministry of Health and Environment, the DH.
Nowadays, people surreptitiously use alcohol and analgesics because doctors are too rich. So, surreptitious drinking and analgesic consumption produces erosive gastritis, leading to very severe anemia, both in men and women. Women also now, with gender equality in our villages, they have taken up the challenge.
Any quick questions?
Yeah.
Yeah.
Hello.
No.
Hello.
Okay. Oh, you go ahead. Yeah, please go ahead.
Yeah, I'm Dr. Preeti and I'm the physician. I want to ask that there are so many policies in made since 1992, but the main thing is that the compliance is not there. The most important thing which I feel is that the compliance is not at the ground level, because most of the people who are in the poverty level, they are in the villages, and we are not able to reach them. Basic the facilities which are provided by the government, we are not able to help them out. So are there any policies being made at the ground so that we can help those people at the ground level?
You want to do this? Yes, sir.
Thank you. I see your point. I agree with what you're saying. But at the same time, we can't throw up our hands and say that since we cannot have that last mile connectivity, we should not do anything. If you look at the kind of biggest revolution that's occurred in the smaller and peripheral areas, we've got two-wheelers penetrating just about everywhere, and the mobile phone has reached the whole landfall ever get of making a date. And this means that you can have a suitably trained home care worker or a home service delivery person reaching a home And the way to monitor whether that person is reaching or not today should be using a mobile phone, GPS and internet connectivity to see that there is a contact between an agent of the state, whether it's an Anganwadi worker, Asha, or some other kind of person, and the woman, and something changes there, which can be monitored remotely. Because let's be very clear about this. Many of us are highly motivated, highly inspired, we want to do good, but when you start looking at thousands and 10,000 workers, if there is no supervision and if they know that nobody is watching and nobody is checking, you'll have a certain fraction like 40 to 60% simply bunking duties are not doing their job. And you'll start getting healthcare on papers. I often say public health or PH is actually paper health. It doesn't really happen, but gets reported. So I think we should take the advantage of technology, but let's not also get carried away with technology and assume that just because we went and made some software and had a surveillance system is going to work. It will need hard work on the ground, and we need to find a way of motivating those who are running such programs. Even if we haven't done it, we can't abandon the system.
I think we need to bring it to an end, but one thing that I would have liked to see. You want to make a quick comment, Dr. Datta?
Mike, did you?
You see, it's very interesting. Every point that has been made is very relevant. But my humble request to this meeting is, let us draw a working plan and start working. Then only we will know which is right, which is wrong, which is very correct, which is false. And that's why I suggested one block of tribal, one block of rural, one urban slum of city, one industrial cluster of population. Select it. Let us see how many persons require, what is the type of education, what is the type of nutrition, what are the type of infections to be controlled, what is the cost of this. Then we proceed ahead. Unless we start doing this, this type of discussion, I am listening for more than 30 years. And second thing which I don't have just now discussed is our eating habits. We are not talking very nicely like fruits I have listened. But second important factor for poor iron absorption is the tannins which you are consuming in the form of tea and coffee. They inhibit about 10 to 20% of non-heme iron absorption, that is in our vegetarian diet, fruits, vegetables, and our green leafy. Now, there can be a simple statement that at least college-going girls take home, come from home after taking a lunch. As soon as they reach the college, they go to a canteen and start taking tea or coffee. Every office they come to office and first thing they do is have some tea or coffee. So this is inhibiting the iron absorption. This has been very correctly estimated by Dragman, not as anybody else. So let us limit for 3 hours after meal or breakfast. Don't have any sort of tannins at least in your. These are the two things which I thought we can act on. Thank you.
Thank you very much. In fact, thank you for this information. I don't take tea or coffee. My hemoglobin is always 15.5 or around. But I think. Yes, please.
Just wanted to add what Sir said was that we are coming from an organization working in people with disability. And when any data is collected, etc., just wanting to understand how much focus is actually given on disability per se. Here, like for example, malnutrition is one of the real causes of disability. So when we are doing a survey, when we are trying to do any sort of what you call data collections, I think it's very important to add that aspect of how many children with disability there are and what are the causes of those disabilities and why is it malnutrition, and if it is malnutrition, then what are the things? So if we could just add that to it, please. Thank you.
Sure. Thank you very much. In fact, as you are aware,
Also,
the next.
I'm sorry.
Yeah.
See again, I mean, working in the field of disability for the last 20 years, when we work in the slum areas, and a lot of children don't go to school, and then there is this thing, the school children. There is a program whereby school children do get iron tablets to combat anemia, but the children with disabilities who are not going into any school, not they go to any Anganwadis. So how do they get their this thing? How do they meet with their needs? That is also something that we need to.
Right. It's an important point. But I personally also work in the disability area, and in the afternoon session we have discussion on assistive technology. But what Dr. Davke said was something that I was going to say anyway. That this discussion is not an end point, it's a starting point. The grant is one that we have identified. This discussion is a starting point for a roadmap that TIFAC, in conjunction with ICMR and other agencies, will prepare. The one data that I would have liked to see that we have seen the various programs, we have seen the result work. What we have not seen the statistics, how it is changing, how it is impacting. That data I could not see that it's changing every year, we are improving. But that information I have not been able to see. We have seen that 58% or something, but in last 5 years intervention, what has happened? Of course, we can correct the data, we look at that. But this is, as I said, that is a starting point, not an end point. This was a way to get people together. And thanks to ICMR that we could get together and we have all of you. So your feedback, even if you're not able to give now, this is a starting process. It's not an end process. You will participate in this. So I think at this point, I would like to end this just because you run out of time. There are many important points to come. So thank you very much. And I think thank you.
We thank all the panelists for giving whatever the maximum possible way in the shortest possible time, the insight of their own work. From point of view, TIFAC is going to bring out action plan document of this Grand Challenge 1. Likewise, for other 10 Grand Challenges we do, with involving all the stakeholders. So that is the action TIFAC and ICMR together. Now I have to close the circle. The sweet duty our ED will do, the token appreciation for all the speakers, all the panelists, momentum.
I will start from Dr. Chandrasekhar's side just for convenience. But for photograph purpose, they want us to look at it. Thank you. So maybe you can come up a little bit because the photograph doesn't come well. So we want to make sure that.
Now we break for lunch. Our Honorable Minister will arrive here at 2 o'clock. The formal inauguration of these 2 day events will be at 2 o'clock. I here, sorry to cut out the lunch part, but there's no other way. Thank you.
उसको बाद में देखेंगे जो देखा लाइव से यार पता नहीं समझ नहीं आ रहा बदल से लग रहा है इसको बंद करो तुम का ले लेंगे को शाम तक चल जाएगा
देख लीजिए जब आएंगे तो चलना चाहिए
वो एक बार देख लीजिए
इम्पोर्टेंट या तो चलने दे सकते हैं चलने
मतलब हो जाएगा 1 घंटे का गैप आएगा कट शॉट नहीं कर सकते